evening. Thanks to each and every one of you being here with us today. I, Amit Saxena, along with Dr. Deepika Chabra from Jagsonpal Pharma Ltd, are very pleased to welcome you all to the webinar on research methodology organized under the aegis of AOGD and General Committee of Midlife Health, Indian Menopause Society in collaboration with Sir Gangaram Hospital, Delhi and SMLM with academic partner Jagsonpal Pharma Ltd, makers of LycoRed Yuliprist. Dear attendees, if you have any questions, suggestions, clarifications, please post it in the chat and Q&A box. Please note this webinar is streaming live on Facebook and the link is already being shared in the chat box. Please note, for future references, we will upload this webinar on Jagsonpal YouTube channel, Jagsonpal Medical Insights. Thank you very much for listening, and let us welcome Dr. Mala Srivastava, Professor GRIPMER, Sir Gangaram Hospital, to kindly initiate the program.
Good evening, everyone. It's my pleasure and privilege to set the ball rolling for this evening webinar on research methodology, organized by Sir Gangaram Hospital under the aegis of AOGD, Journal Committee of Midlife Health, Indian Menopause Society, and Society of Midlife Management. Faculty for above webinar has come from all over India to spread knowledge on this important topic of research methodology. Research is an integral part of science. That's why we have to innovate, upgrade ourselves. It's my proud privilege to invite Dr. Maninder Ahuja. Madam, this program was conceptualized by her, and I'll invite her to give the welcome address. We all know Dr. Maninder Ahuja, who is the President, Society of Meaningful Life Management. She's the Director, Ahuja Health, Dental and Fertility Center, and ma'am has occupied so many important posts and has been so much instrumental in doing all the academic activities all over the place. Over to you, madam, to give the welcome address.
It's a proud privilege to have the glittering faculty from all over India, as Dr. Mala has already mentioned. It's from the east, it's from the west, it's from south, and it's from all the medical colleges of Delhi and all the institutions. And all of whole of this faculty is experts in their own field. And of course, they are doing lots of research also. But COVID-19 has taught us the importance of research. Research is the basic for the good clinical practice that is very much required. Perhaps in India, we are not able to produce so much of evidence as we should be producing in the past. Future COVID-19 perhaps has taught us and brought us together. All the world came together for the research on COVID-19. That's why we could do these things so quickly. So what it has taught us is the collaboration. So when we are doing a research, it's not your job, his job, her job, this association's job. It is we are doing for the health of women of this country and globally, health of women globally. And that is what matters. Nothing matters beyond that, that we have to somehow look into our clinical practice guidelines, improve them. That's why I had my first paper on age of menopause and the determinants of age of menopause, where the Jagsonpal helped me a lot. Then we had guidelines of the Menopause Society. Then we have recently weight management guidelines with Dr. Piyush from All India Institute of Medical Sciences. With WHO, we have produced guidelines for menopause hormone therapy in the private practitioner. So now I request all of you to please join in this project of South Asian Menopause Societies, which is the relationship of menopause to metabolic syndrome. And all of you know the incidence of metabolic syndrome in the menopause rises from 16 to 64% even. And it's a simple project. So I request all of you, please to become part of it. It has two arms. One is with the healthcare professionals, 35 to 60 years, and another is cross-sectional studies in your own clinics. I'll be sending you links and the format for each and every one of you to be part of it, because what the data is coming now, I'm looking at is really, really scary. One of my colleagues had written a article on PIH years back, and I asked him, he asked me, what is, Maninder, how is that article make? Article is very good, but what I'm looking at is the epidemic of metabolic syndrome, which is going to be there in our country. And if we don't prevent it, we are going to be at a very great loss. And that is what is happening. So please, all of you join in that project. And this group is, I think, going to be the torch bearers, because they are going to initiate all the doctors, all the practitioners into doing some sort of research. Each and every one of you can collect data at your own level. So over to you, Dr. Mala Srivastava. And first of all, I have to thank her from the core of my heart, because I just called her, Mala, I have joined as editor of Journal of Midlife Health, and I want to do this research methodology webinar as the first project. Will you please help me? And look at this. She has made it such a beautiful, wonderful, out-of-box webinar. Thank you, Mala Srivastava, and thank you to all the faculty from all the corners of the India. And my heartfelt welcome to all of you. Please, over to you, Mala.
Thanks, ma'am, for your encouraging words. It's my pleasure to invite our chief guest for the evening, Dr. Shobhana Mohandas. Madam is the president of Indian Menopause Society, and she is consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur, Kerala. And it's our pleasure, we request her to address our gathering for the evening. Over to you, madam, for your pearls of wisdom.
Thank you, Madam Mala Srivastava and respected Dr. Maninder Ahuja. And I thank you all for inviting me to this event. I feel humbled in front of so many galaxy of, researchers. All I can say is, yes, Indian Menopause Society, besides Dr. Maninder Madam's study, is also conducting a study on hot flashes, incidence of hot flashes in India. I hope many of you who are attached to Indian Menopause Society would have got the forms, and I request you to also fill those forms in addition to the metabolic syndrome form, which is a South Asian study. Yes, we are 5th in Elsevier's. Do you know that? We are 5th in Elsevier's in the amount of research produced. And that in spite of the fact that we are only 70 years old as a known nation. We were existing for 10,000 years, 55,000 years, that's a different thing. But as allopathic medicine, followers of allopathic medicine and this English medicine, we are only 70 years old. And before that, UK has a research from, 17th century, 16th. US has got research from 400 years. We as a nation have started producing research only since 70 years since independence. Still, we are 5th. But we are the least cited. Why? Because people like you did not exist before. People like Mala Srivastava, people like Maninder Ahuja, who thought that we should be teaching how to do research and how to produce, show it off to the world. So therefore, we are little behind. And I'm very sure that webinars like this, we will make us reach first, and we will get cited even though we are producing so much of research paper. We are not cited because people like you have to do more and more work. So I thank you, Maninder ji, Mala ji, and all the learned people here for letting us into this. I can see my friend Asha also sitting there. We are very old friends since 1995, I think. And Sampath Kumari, Anita, all friends here. So with that, I wish you all the best for this. And all you luminaries can help catch India reach that first place. Thank you so much.
Thank you, Shobhana. And we are with your project of hot flashes also. So the hot flashes and metabolic syndrome, they go hand in hand.
Nice seeing you, Shobhana.
Hi, Asha. Hi.
Hi.
Hello. Thanks, ma'am. Thanks for your encouraging words. It's my pleasure to invite the expert for the evening, Dr. Sharda Jain, madam. Madam is the Secretary General of Delhi Gynec Society, and she has been the professor at PGI Chandigarh as well as Lady Hardinge Medical College. and she's the director of Lifecell Center and Lifecare IVF Center. We have our second expert, Dr. Asha Roy. Madam is the Madam is a chairperson, Endometriosis Committee of FOGSI, and she has been an experience of 25 years in ART. She's the director, Rao Hospital and Care, Coimbatore, director for postdoctoral fellowship program in reproductive medicine and endogynecology. Madam is affiliated to Tamil Nadu and MGR Medical University, Chennai. Welcome, ma'am. And we are very happy that you have accepted our proposal of being an expert for today's evening. Thank you, ma'am.
Thank you so much, Mala. I'm much honored to be here with all of you today. It's a wonderful program that you have arranged because I think research methodology, the more I learn about it, I feel I know how little I know about it. So you consider me as one of the students today, very hungry to know more. And I'm very happy to have such a galaxy of speakers and chairpersons. We have Dr. Maninder, Dr. Shobhana Mohandas, and we have Ruma Shukla, Radhika, Lakshmi Shrikande, Ashish Kumar, Sampath Kumari, and we also have the chairpersons Priti Kumar, Rakesh Singh. There is such a big galaxy, and I'm sure we are going to infuse so much of knowledge. And all of us, let us enjoy this vibrant scientific session. Thank you, Mala.
Thanks, madam, for your encouraging word. Now we can go to our scientific session. For the scientific section, it's my pleasure to invite the master of ceremony for the evening, Dr. Ridhi Narang. She is the clinical assistant, Gynae Endoscopy Unit, Sir Gangaram Hospital, and she is a young, enthusiastic, dynamic, very intelligent young gynecologist of our institution. Over to you, Dr. Ridhi, to carry on the scientific program.
Thank you, ma'am. And thank you everyone for joining. For the first session, I would like to invite chairpersons. I would like to invite Dr. Neerja Bhatla. Ma'am is professor and head of Department of Obs and Gynae at All India Institute of Medical Sciences, Delhi. And also ma'am is Vice President-elect North Zone FOGSI. We welcome you, ma'am. I would like to invite Dr. Chandra. Ma'am is senior consultant.
Gujral and Dr. Priti are caught up somewhere, so we are requesting Dr. Chandra to chair this session.
Yeah, Dr. Priti, I'm there.
Yes, ma'am. Ma'am is a senior consultant at Sir Gangaram Hospital, Delhi, and ma'am specializes in gynae endoscopy and robotic surgery and adolescent health. We welcome you, ma'am.
Pleasure to invite the first speaker of the session, Dr. Ruma Satvik. Dr. Ruma is a consultant, Center of IVF and Human Reproduction Center of Sir Gangaram Hospital. And we know she is a very enthusiastic and very dynamic consultant of our hospital. Over to you, Dr. Ruma, for your scientific deliberation.
Thank you, ma'am. I love talking about research. It's also a learning experience for me in many ways. And however, this topic that has been given to me today is something I have spoken on various occasions in the past. And I hope we are able to talk about or at least take home some messages through this talk. The topic of deliberation today given to me is types of research and choosing a research question. And the objectives of this talk are largely to look at what are the different kinds of study questions that students come across while looking at their thesis, how to choose and what are the study designs based on these questions, and specifically description of these study designs. So what is it that we are really looking from a study question? And while there are several mnemonics that exist which specify what really constitutes a good study question, there are 5 very relevant aspects that I would urge students to look at. And first of them is novelty. Novelty need not mean that it is a completely a new question. It's never been researched, but it could be a question which has been, or an issue which has been looked at in the past, but there are some aspects within that issue that still have some gaps remaining, which have not been answered or have not been answered to satisfaction. So when there is literature that exists on the said issue, but there is clinical equipoise, or we talk about that there's no clear idea as to which way to steer, we use the phrase clinical equipoise. Even that would be considered a novel question if you were to use a good study design and use the right number of participants. The second is relevance. So whatever question you have in your head, whether this is scientifically relevant, if at all. So you cannot, for instance, just design a question because, or design a study because something appears in your head right away. It has to have a logical sort of a cause-effect relationship should have been established in the past. And here you are trying to look at, an aspect which is further than just the cause-effect relationship. Feasible, the third thing that students should be urged to look at, and this is where major study questions would come to a halt, is feasibility, is whether this is practicable, whether it can be done in the clinical environment that one is working in. So one could be restrained by time, costs, sample sizes, and all that. So one has to try and choose questions which are possible within the 2 years or 3 years duration that they are working in their institutes. Of course, there are two other aspects, interesting, and so this is a question which should be of interest to the general public, should be timely, perhaps where the uptake of the results of such a question are likely to be high. And what we shouldn't ever forget is no matter whether our question was scientifically relevant, it was logical, it was new, whatever. But if we are going to recruit patients in a way that is going to be unethical, maybe not looking at patient harm, patient autonomy and consent, then again, your study question is not going to be considered a good enough study question. So these 5 points come together in the mnemonic FINDER, and this is what most guides would urge their students to use these 5 important criteria while defining or designing a study. Now, there are practically, if you look at it, there are essentially 6 kinds of clinical questions that could come to you. First is, what is this condition? Now, this condition could be, it has to be, unless you've been living under a rock, you will not be able to really, and you haven't done your literature research properly, you'll probably come up with, things that are already known, you might want to define it, which is not the right thing. So the condition has to be new, it has to be something rare, for you to be able to report it either as a case report, or if you have very many cases, like more than 3, as a case series. This is known as a descriptive study. The second question, clinical, that yes, this is the condition, what is its prevalence? And this would come together in what is known as a prevalence study. We will be talking about this design shortly. It's usually a cross-sectional study wherein we enroll a certain group of individuals within a community, within a time frame, or within a clinical setting, and try to look at certain attributes or distribution of certain traits within this population, which will tell us how prevalent a certain condition is. The third clinical question is, what it is, its traits, how much it prevails. Is the third thing that you could possibly ask is, how does it happen? Why or how does it happen? And this is a cause-effect study or an etiological study. And mostly the study designs are observational in studies known as cohort studies or case-control studies. Animal trials can be used to define etiology, not human trials, wherein you expose the animal to a certain harmful agent, or let's say a disease agent, a microbiological agent, to study whether that certain disease or its severe form or mild form develops or not. The next is, now you know how it develops. You want to know how to diagnose it and what is the best test to diagnose it. It's diagnostic study, and the designs are prospective, interventional, or case cohort. We'll be talking about this as well. And then comes the most important question: what is the best treatment to treat a certain condition, or what is the best treatment to treat a certain group of individuals? So this is what most of you will deal with while writing your thesis. Not so much prevalence studies or etiological studies, which come under the domain of public health experts and preventive and social medicine people, but a little more of diagnostic studies, but many, many more of effectiveness studies is what you would be dealing with in all likelihood. So what is the best treatment for this condition is best answered, the best design to answer this remains a randomized control trial. If you have enough time and your study question is relevant, it's feasible, you certainly undertake a randomized control trial. Otherwise, the other study designs to answer this could also be a cohort study, and in a rarer situation, case control designs as well. The final question that one may have is looking at how patients perceive the treatments that you are giving them. And these are best answered by a qualitative study design, survey, or questionnaire. And these could be done through interviews, surveys, sometimes also an RCT, where you're trying to look at patient perception of intervention 1 against intervention 2. So we're not going to go into the details of case control and case series. You probably already know that. We're directly jumping on to question 2, which is you're looking at the prevalence of a condition. It could be, for an example I've given you, let's say prevalence of tuberculosis in the community. You suspect that things have changed in the past 5 years, ever since the advent of the new drugs, anti-TB drugs, or probably, better living conditions, or perhaps better nutritional conditions within individuals, and that perhaps the incidence of TB or prevalence of TB is not as much as it used to be, probably in the 50s and 60s. So you want to undertake a TB prevalence study within the community, right? So that is one example. Second is, it could be a normative value prevalence study, wherein you want to look at, let's say something like, what is the normative value of TSH in pregnancy amongst Indian women in the first trimester? So you could design a study around it, provided, of course, you've done your literature review and it tells you that there is no such study done in the past. It could have to do with population trends. For instance, what is happening to menopausal age within women? Is it increasing? Is it decreasing within birth cohorts from the 30s, 40s, 50s, 60s? Of course, you're looking at a huge data. You're looking at a door-to-door survey, or you're looking at data from, let's say, there are registries being maintained by the government of that of menopausal ages and birth ages. Only then can you do these studies. Perhaps not so much in India, but I'll give you examples of how these studies are done outside. So prevalence studies are, like I said, you could also put them in the bracket of descriptive studies. It describes characteristics of population, distribution of a trait or trends. The study setting could be community or hospital. Community setting, we already, so for instance, incidence or prevalence of infertility in Delhi, do we know that? Or do we just know it from our clinical practices? So we understand that hospital settings for prevalence might be a limited setting. It might overestimate the prevalence of a certain condition, because this is where women will concentrate if they have problems. So it might not be the best situation to do a prevalence study, except in cases where, let's say, you're looking at the prevalence of infertility in women with autoimmune disorders. Now, autoimmune disorders are such a rare condition, you might not find it, in the community. You might have to have a very, very large sample size, maybe 100,000 houses you'll have to survey to find that, and then look at infertility prevalence. As opposed to this, looking at, let's say, the rheumatoid arthritis clinic in your hospitals, and picking up women from there in the age bracket 20 to 40 reproductive age group, and probably that's how you can try and determine what the incidence of infertility in this age group is. So some questions are good for a hospital setting, some questions are good for a community setting. You have to know what the difference is. Finally, when you're doing these studies, you have to have an exact case definition. You have to have the right sample size. The sampling has to be representative, representing all kinds of individuals within the community that are relevant to your question. These studies do not require a control group, and you do not have a hypothesis to begin with. So in the examples I gave you, we have no hypothesis like tuberculosis. I mean, I may have it in my head that TB prevalence might be different now from what it prevailed in 1950, but I have nothing to compare it against. Similarly, what the average value of TSH in pregnancy is, I have no hypothesis. I'm just looking at what the median is, right? So this is one example of a prevalence study, and this comes from India. The authors come from India as well. So here they're looking at distribution of PCOS phenotypes. So you already know there are 4 kinds of phenotypes across 4 regions of India, and if there is any difference, if at all, one could find in prevalence of these phenotypes within Eastern India, Northern India, Southern India, Western India, and blah, blah. So they find something significant here. You see that the numbers are quite decent within each block, East, North, South, and West. And they find that the distribution of type C phenotype, type C would be hyperandrogenic but ovulatory kind of PCOS. So what are the 2 criteria present? The PCOM morphology is present, hyperandrogenemia is present, but this is a regularly menstruating woman. So while the incidence is high of such phenotype in North, South, and West India, but it seems to be pretty low in Eastern India, right? And similarly, you find some other differences if you were to look at it. Clearly, we did not have this idea before this study came around. So it manages to get published as well, because this is a novel question that the study is answering. Similarly, we get back to thyroid normal values or normative values in pregnancy. And here they're looking at within Indian women. So even though this is ethnicity specific, and mind you, most journals will not publish studies if you write experience from India. But here, what this gentleman manages to prove, and also gets it published in British Journal of Obs and Gynae way back in 2008, is that the median value for TSH in pregnancy, first trimester is 2.1, in the second trimester is 2.4, and in the third trimester is 2.1, with the 95th centile being at 5. So clearly 5th to 95th centile, so 95th centile is much higher than what is defined for the Americans. So we understand that 2.5 and above would be considered high in the first trimester of pregnancy, but not so based on this study in India. So we have to try and locate such studies and see how things would be different for us than for others. And here, this is an example of changing trends in reproductive lifestyle factors in women. And here there are 4 charts, basically. The first one is talking about the age of menarche, which seems to be going down with birth cohorts, 1930, 35, 40, 45, and 50. And here it's talking about the mean age of menopause in years, mean age at menopause, which seems to have gone up from here to here. And then again, there are other charts. So what it is talking about, but then it seems to have come down a little after the 1950s, right? So these trends, these are valuable charts, valuable information that is gained from some studies. If you are into it, I would urge people to undertake prevalence studies. These are very, very valuable studies for public health, for policy making, for other reasons as well. So we come to the next study question. We're talking about etiology. So one wants to find out what or how is this condition happening, in which case, and when we are talking about that, and we have, let's say, a hypothesis in our heads, something like, is state X correlated with state Y? We move into the realm of what is known as analytical research. Okay, so far it was descriptive. Now we are moving on to analytical research. So the question so in the previous example, you saw that the menopausal age was actually going up from 1930s to 1950s and thereafter declining. And now I have a hypothesis in my head. Is it because of the increasing incidence of hysterectomy? Is it because of smoking? Is it because of any other parameters? Whatever the researcher can think of. And then you could perhaps design a study around that. When you have, let's say, an attribute and you're trying to investigate how much that attribute is responsible for an outcome, you move into the domain of analytical research. So analytical research is hypothesis testing study, wherein you have a comparison group and your purpose is to establish an etiological relationship. There are two ways of doing this. One is observational and the second is experimental. The difference is that in experimental trials, the intervention is assigned by the researcher, and in observational, the intervention is not assigned by the researcher, right? So you basically observe the outcome or the natural history of disease without changing anything about how things are progressing naturally. So when are observational studies better than interventional? Let's consider these three questions in order to answer that. So we are looking at etiological study designs. Will we prefer interventional? Will we prefer observational? So here is low AMH linked to low live births in IVF, okay? Cause, effect. Can we change the variable? Can we design an experimental study out of it? Not really, because you think about it, the feasibility of an experimental study in that case, you cannot. But what you can do is you can't change the variable that is intrinsic to the subject. This is best undertaken as an observational study, either as a cohort study or as a case control study. So you undertake observational study when the variables are intrinsic to the subject and cannot be changed. The other question is use of ovulation induction drugs linked to greater risk of cancer, ovarian cancer? So at the face of it, ovulation induction drugs, yes, is not an intrinsic variable to the subject. You can add it or you needn't add it. So it may lend itself to an interventional study design, except that the outcome, ovarian cancer, is so rare and it is so delayed. And in fact, here in this case, if I know and if I'm telling the participant that it could lead to cancer and I'm giving away ovulation induction drugs, let's say, 10 times or 12 times, it becomes unethical. In such situations, designing an interventional trial will be unethical. It will be non-feasible. So here you would undertake an observational study. Third is, consider this: is surgery for CIN3 better than no intervention? So here, this question itself, we know that the outcome of performing a surgery is so much better than not performing it, that non-intervention becomes unethical. Okay, so these are the reasons where the variable is intrinsic to the subject, where the outcomes are delayed and rare, where intervention is unethical, or where non-intervention is unethical. We undertake observational studies over interventional studies. Types of observational studies are case control or a cohort study design, right? So we are not in a dispute there. We can, all of us know this. And a case control study design typically looks like this. You know that, so the outcome has already happened. Let's say the outcome was women with epithelial ovarian cancer. So here we are undertaking the question of whether epithelial ovarian cancer is likely to happen more frequently in women who have received ovulation induction several cycles in the past or not. So let's say we're looking at women with epithelial ovarian cancer, those become our cases, and women without epithelial ovarian cancers become our controls. Where will we find so many epithelial ovarian cancer cases? Again, there could be registries, there could be, either maybe if there is an Indian Cancer Society or Oncological Society, we perhaps go to them to see if there are any registries that list women who have it. So within them, we try to look at whether the exposure of ovulation induction was present or not. And again, it's not just 1 or 2 cycles. We are looking at perhaps more than 12 cycles with this having received it or not. And following this, we make our charts, exposed, unexposed cases, controls, and calculate the odds ratio, which is ADBC. I'm not going to be talking about that, but that is a typical case control design done best when the outcome is a rare outcome or a delayed outcome. A typical cohort study design looks like this. You have a study population. Within them, one set of individuals has received the exposure and another set hasn't received the exposure. And you follow them in time forwards to see if the outcome has occurred or it has not occurred, and then divide, sort of do your tables like this and calculate what is known as the relative risk, A upon A plus B divided by C upon C plus D. I'm sure this would be spoken about in one of the talks. So with this, we come to the 4th question, which was on, we have described the condition, we have found out why this is happening. Now we are looking at, we've described how much of it prevails, and now we're looking at what is the best test to perform to diagnose a specific condition. So 2 common kind of examples that we take are accuracy of AMH for predicting poor response after COS in IVF, okay? And the other one I have also taken is accuracy of RT-PCR in diagnosing COVID disease. So we have 2 kinds of study designs here, a prospective and the other is case control. Prospective is generally considered the superior design. Now, this is what a study on, let's say, that question, AMH in predicting poor response to standard COS and IVF would look like. So you have a bunch of infertile women undergoing IVF, and all of them, so there are no controls here, as you can see, the entire cohort of women who are undergoing IVF go through one is the gold standard test, which up till 2010 was considered a day 2-3 FSH. And then till AMH probably was used much more widely. So we're talking about the period more before 2010. And you also run an AMH test on them, right? Based on the day 2-3 FSH, a conventional COS is given, an oocyte pickup is done, and you classify your poor response or good response based on standard definitions. And now you try and determine first, so this is a prospective interventional design. So at the end of it, you will have something like this. You will have an ROC curve where AMH is able to predict poor response. The greater that blue line, the closer it is to 1, you know that it has a good predictive value. And the closer it is to the green line, you know it has lesser predictive value. So we were able to find out that AMH is able to predict poor response much better than day 3 FSH alone. So we'll just go on because there is a lack of time and I have to be on time here. So we'll just go on to the next question, which I said is to students might be the most common kind of question that they will have to deal with and they will have to answer. It is the question of effectiveness of an intervention. Would intervention A lead to outcome X, right? Or is intervention A better than intervention B for outcome X, right? So comparison between interventional groups. So let's say we take the example of PGE2 versus PGE1 for induction of labor and vaginal delivery. So let's say if our outcomes were vaginal delivery, we are looking at E2, E1 to start labor and to end it in a vaginal delivery. That is our outcome. So we are looking at effectiveness study. What are the designs for this? So here, like I said, there will be an intervention assigned, right? Which is how you study the effectiveness of that intervention, which is why it comes in the realm of interventional analytical research, also called trials. Trials are the best designed for answering effectiveness questions. And so like I've already explained this, if the intervention has been assigned by the researcher, it is called a trial. If it has not been assigned by the researcher, it becomes an observational study. It will have a control group, but sometimes the best designs are with a control group, but some study questions, and I will be seeing that shortly, might also be answered without a control. there will be randomization. So we also understand, and we use the term RCT so commonly, that randomization as to why it is essential. Blinding and design, I'll not be talking about blinding and design for lack of time, but we'll definitely be talking about control group and randomization. Okay, so there are things I said, some questions can still be answered best with an uncontrolled study, although controls are necessary to give you the counterfactual. What happens if you don't intervene is answered by the control arm. The control arm is also giving you a base above which or below which the intervention is acting. So you need that base in order to determine whether things are working or not. However, here I'm giving you an example of what are the questions that can still be answered by an uncontrolled study. So there are two kinds of studies where and acceptably you can do it without a control. One is single arm studies. These are phase 1 trials for drugs, for vaccines, for devices. These are known as safety trials, wherein some 10 or 15 people receive the intervention and one looks at the adverse effects of those interventions. Phase 2 trials are efficacy trials. More people, 80, 100 people receive it, and one looks at how that drug is going inside the body, doing what pharmacokinetics, so some biochemical parameters and other things will also be measured. And then you have the before and after study, where it's the same set of individuals, how they were before the intervention happened and how they are after the intervention happened. So one example of a before and after study that does not have a control, the same people actually serve as their controls, are pain scores before and after surgery for endometriosis, right? Now, we are looking at why should controls be necessary? Why are we looking at controls? So let's say this was a question: will IUI help a woman with unexplained infertility of more than 1 year have a baby? And so intuitively, we will say, yes, it should. Will some of us be able to answer how much after each cycle? Perhaps some of us would, not all of us may. But would some of us be also able to answer how many cycles will be needed to get, let's say, half the mouse pregnant? Perhaps some of us will be able to answer not all. But we are looking at that these outcomes also happen within individuals who don't receive IUI. So how exactly do we determine the effectiveness of IUI as an intervention in this population group? Is by looking at a control group, same kind of population characteristics, who do not receive that intervention. So I already told you, control group gives us the counterfactual, what happens when the intervention is not undertaken, and it helps to quantify the effect of intervention over and above of what would have occurred by chance or naturally. So in the example we just saw, IUI, we can say, might be 2 times as effective in this population if and that's pretty decent, right? So the next we come to randomization and its necessity and its need. So we understand that if I were to put women in the group of IUI and women in the group of observation, I might be biased. I might be biased because I might put the better prognosis in one group and the lesser prognosis in the other group. So I might be biased in patient selection. Good prognosis could be allocated to IUI arm, and I may not know if the final result is because of IUI or just because of my bias. So corrective is randomization and allocation concealment. This needs a separate topic. I'm not going to go into that, but randomization is basically picking up patients of the same characteristics and not knowing who is going into what, using computer generated sequences or let's say toss of a coin, something like that, to allot the next patient into what arm they would go into. Allocation concealment is that when I put a patient in one arm and the other in the other arm, based on those computer generated sequence, it has been concealed in a way that I don't know who's receiving what treatment. So for instance, randomization might still be revealed to the researcher, right? At some point that 2, 5, 10, and 15 are to go into arm 1. 1, 4, 6, and whatever are to go into arm 2. So I know 1 has gone into arm 2. But if there was a way of concealing it, like for instance, medicines can be concealed, 2 medicines can be designed in the same way, and that is known as allocation concealment. So those are ways to prevent any bias that might happen because of patient selection. There could be bias because of outcome assessment. One example is ultrasound assessment of endometrial thickness, and this can be best addressed by blinding the observer, blinding the person who reports the outcome. And in outcome reporting, where numerator and denominator of convenience are often used. So I might just choose to kind of, so these are some examples I use in infertility, but here, for instance, I might just look at what the clinical pregnancies in IUI were. And I don't look at, let's say, live births, because IUI also use medicines, and most of my pregnancies ended up in multiple pregnancies, and some of them were lost, let's say mid-trimester. So the end result, which was a baby to the, a live birth to the woman, has not been achieved. So we have to use standard outcome measures for whatever subject is being used. So well done RCTs will minimize unintended bias. This is what we need to remember. Okay. So when we are,
Kumar, can you wind up within a couple of minutes? Can you wind up?
Yes, ma'am. This is the last slide. After this, there's one more slide. This is the second last slide. So framing a research question of effectiveness, whenever we have to frame a research question, PICO is something that students should be aware of. P stands for population, I stands for intervention, C stands for comparator, and O stands for outcome. All effectiveness studies will have to have this defined. So would IUI in a stimulated cycle be more effective than our observation alone in women with unexplained infertility of 1 year or more? And I have divided what is the population here, what is the intervention here, what is the comparator here, and what is the outcome here. Right? Please remember that whatever studies we do, the largest samples are still a fraction of the whole. And when we kind of do a badly designed study using a poor methodology, the results can be very, very different. Good study designs, in effectiveness studies, if you're looking at RCTs, for instance, will come closest to representing the whole. You will never know the complete truth, but a well-designed study will be able to do that, right? So I'll forego this, but I leave you with this slide, which is basically summing up what we have spoken about. What is this condition or procedure? Is called a descriptive study, best answered by case report, case series, descriptive studies. How much does this condition prevail? Answered best by a prevalence study. By prevalence studies are cross-sectional in design by nature. They could be community or hospital-based. What is the or diagnostic study designs will answer questions like, what is the accuracy of test A for diagnosing condition X? You have 2 study designs, prospective cohort or case control. Cause-effect relationship can be answered by observational studies. If we're looking at time, cost, and ethics factors here are best answered here, but also by interventional studies in some cases where we will do randomized control trials. Comparison of treatment effects best answered by RCTs or before and after studies. Sometimes you will also undertake observational studies for time, cost, and ethics issues. And lastly, how do patients perceive treatment? You would use the qualitative study design. Thank you.
Thank you, Dr. Rumak, for your excellent lecture. And you beautifully explain about the various types of the research studies and the methodology. And you really explained beautifully that how to choose a topic. And according to your questions, whatever in your brain, you would like to give the printout, and you have to explain whatever you want, how to design your study according to your requirement and in your premises, whatever is possible. So you beautifully explain all type of the descriptive, prevalence, cause-effective, diagnostic, and effective studies, and how to do a case control study and cohort study designs according to your requirement. So I think you beautifully explain and in very simple words that everyone I think can understand. I could understand even more than 60-70%. I used to, I think, I don't understand this type of the studies, but today I could understand something from your beautiful lecture. So thank you, Dr. Ruma.
Dr. Ruma, I would like to comment on one thing, that I agree with you that study design has to be good. The questions which are being asked by the study and answered, they have to be designed properly, because we have a great example of $1 billion study, WHI, going wrong because of a bad design only, because they wanted prevention in the women by HRT, the women who already had the disease process in them. So that is where they went wrong. So now the naturally more introspective studies and more descriptional are coming, because the result was leaked out very early before they could analyze the study. So what is very important is to analyze the study. It's not only just to make the study, it's collect the data, it's the analyzing the study later on, which is the most important part of the study, I think. I think, Ruma, you have made the things quite easier, but to reach out to the practitioner, I think we'll need more sessions. So what do you think practitioner can do very easily in their own practices, sitting at what type of study they can do?
Cohort studies are perhaps easiest if they have kept records. Records is, and I think that is—
We are not keeping. We are not keeping.
I think
can we do cross-sectional studies, which are
or observational studies? Or observational studies, I think we can do very easily. And, and that is the most important thing, how to design your study.
Yes.
Yes, that is the most important thing.
Designing a study, perhaps we'll come back with these webinars again and again.
Choosing a topic.
People like PPH. Okay, what is the treatment of PPH? We have been talking for so many years. So in one webinar, we can't expect people to understand the research methodology. Good.
Dr. Kumar,
otherwise we don't have time.
Dr. Kumar, Dr. Asha here.
Yes.
Dr. Uma, it was a lovely talk, and I'm Dr. Asha Rao. I think I'll talk to you personally later regarding more doubts. There is one question in the chat box, that is from Dr. Uttara. If you are conducting a retrospective cohort study, what should be the number of controls considered? Will 1:1 do?
Not always. It's all right to have different ratios of control, but there are ways of determining the total sample size. So, for instance, I did something on, using the natural cycle method for transferring frozen embryos. And because that was a less performed procedure till the point that it was published, and more cycles were HRT, we couldn't get a 1:1 control. However, there are softwares that will tell you, they will ask you 4 things. What is the expected difference that you are estimating? 1. Second is, what is the base outcome prevalence rate? So base, let's say, live birth. And what is the possible ratio that you are considering? So you have to put that. So this is based on what is the possible ratios based on what I observed. So let's say there were 100 cycles, 173 cycles I found for natural cycle, frozen embryo transfer. These were compared to 511 or 510 HRT cycles. And so this is what the software gave me, that you have to have a total of 700 cycles if you are using 1:3 ratio. So to answer that question, 1:1 is not always necessary. You can use different ratios, but your combined number has to conform to what is considered as the adequate sample size, determined by baseline prevalence rates and determined by the expected difference that you are going to be seeing.
Yeah, because my statistician told me that we need 3 to 4 times the number of controls.
May I add a comment to that, Dr. Asha? Now, it also depends upon the kind of study that you wish to undertake. Is it a diagnostic study? Is it a cause-effect relationship? It depends on the research question, number 1, and also the prevalence of the condition. and other than the other variables that Ruma, mentioned. So, and here it is a retrospective cohort, so it becomes a little more challenging. So it depends on the research question and the prevalence and so many other factors.
Request Madam Dr. Neerja to invite us next speaker, Madam.
Thank you so much.
Neerja has joined. Welcome, Neerja.
Also on the
My
talk.
special welcome to you.
Thank you very much. I'm very happy to be here. And it was a very, very interesting talk by Dr. Ruma. And in fact, I was wishing it would go on. I was rather sorry Dr. Maninder was asking her to wind up. It was fascinating. One of the best.
We just have time restraint, but we'll be having more follow-up webinars. I promise you all. So because I have promised the same.
Dr. Maninder. One is that people should be very clear when they do the research about what is the question they are asking.
Yes.
They should constantly keep asking themselves questions as they see patients. And there should be a question which is a lacuna in literature, because if you don't know why you did the study, it becomes difficult to publish it later. So you should have a plan on what is it contributing new to the literature. And the sample size, as Dr. Radhika said, but more than that, the plan of statistical analysis should also be in place before the study is started. And I do want to say one word about data keeping by the doctors, including private, including public. You know, sometimes human nature is such that we do things only when we are forced to, and that is really sad. But if you read the books of Atul Gawande, which I'm sure many of you have, but Better, Complications, they are fantastic books. And they tell you how even in the midst of the busy Iraq war, when they were so constrained for time, when they were so busy, few people compared to the work, they made it a point to maintain their journals, write down, and that formed the basis for being able to understand which patients should immediately be airlifted to a higher center, which patients could be managed where they were, and they changed the mortality outcomes completely just because they had good data to analyze. So I hope that we can inculcate a spirit of wanting to keep data and wanting to publish it, and that will be very, very beneficial. So thank you, Ruma. It was a delightful talk, and I look forward to your next whenever it is.
Thank you. Thank you so much, ma'am.
Thank you, Neerja, for those pearls of wisdom we really need. And coming from you, they are going to have a better impact.
Thank you. So I will certainly be very pleased to invite the next speaker, who is our dear Dr. Deepti Goswami. She is MD FRCOG, Director, Professor and Unit Head at the Department of Obstetrics and Gynecology at Maulana Azad Medical College, a very prestigious medical college of New Delhi. She's also Honorary Secretary of AOGD, and she has done a Commonwealth Scholarship at the University College London Hospital in UK, as well as she is the Nodal Officer for Maternal Death Reviews. She has a number of publications in very prominent journals, national, international, a great researcher. So Dr. Deepti, the floor is yours, and we look forward to your talk.
The topic allotted to me for today's CME is Guy's role in research methodology. Let me say this at the outset that I have drawn more from my experience while preparing this talk than from the literature. So it's all my practical experience that I gained through my journey as a PG guide over past 12 to 14 years. And this is what I'm going to share with you. So it's all practical, nothing theory, and something which I feel I would like to share. So why do we need a guide? We all realize many of us have guided the PG students, and all of us have been PG student at some point of our life. And we all realize that the students who enter the PG programs have a little knowledge about the research process. Though nowadays they are encouraging some research at the UG levels also, which are carried out with the collaboration with ICMR and all, but not many students who come to us have gone through that exposure. So for the uninitiated student, it's indeed a daunting task. And the guide provides a track for them during their research journey. Practically, it's about guiding them right from the word go, basically help develop a robust structure for their thesis, and then help them navigate through it till the time of writing the thesis. Guide effectively mentors them and recognizes their unique needs. So it becomes like 3 years of attachment to our student as we navigate them through their research journey. Now the question arises, how do we guide the students through the thesis? So I will focus mainly on this, how to go about guiding a thesis and guiding our research of a student. So the first step, as we said, is choosing a correct research question for research. What topic do we have on which to research? So I would say encourage the students to find a subject matter that they are interested in. Many of them indeed are, even when they join the PG course. This motivates them to do good work. Having said that, many times, many of us have our own niche area of work where we feel it's easier to collect the subjects and carry out the research, and we can always discuss with the students, and if they are agreeable, we can, it will be a win-win situation where they work on a topic where we have much experience and where probably we can guide them into a better research question. Consider factors like resources available at the institution. If I don't have an IVF at my institution, then there's no point giving up topic related to that. Feasibility. Do we have resources, lab, buckets for doing the research at which I want to do? Time frame available. This becomes the biggest constraint when we think of guiding a PG students' research, though not for a PhD research where we have plenty of time. And especially when we think of studies which involves follow-up of the patients, then we have to be very, very particular about what number of patients are we going to recruit, how many subjects are going to recruit, and what time frame will we follow. Any special needs of the student. Now, this may appear as surprising, but we have to realize we are getting students with special needs joining even the hectic field like OBS-GYN. Just a couple of years back, I had a student who had problem in mobility. So I had to be very particular about what topic I should give to her so that she is able to fulfill without it being too much of a physical constraint to her. Then sources for literature search. So how do they find the subject? They have to do the literature search. We have to introduce them to the sources for literature search. So far, their reading is limited to their textbooks with so many subjects and maybe the institution library. We have to introduce them to the physical resources as well as the online resources. Now, I think as a postgraduate, everybody should be introduced to National Medical Library. It's a wealth of resources. At least our generation, all of us have been there. But now with the digital knowledge being spreading wings like anything, we have to introduce them to research databases, mainly for our medical research. PubMed and Google Scholar are two very good sources. Because if they search only through Google, they will not get a very good good studies. It will be a little complicated. PubMed and Google Scholar, they sift out the research studies so that they can get more filtered results. How to search? They won't even know how to search. I always sit with them and teach them how to use these resources, use correct keywords, and how to then save those articles either in their clipboard or mail to them. Then familiarize them with the terms like index journals, types of studies which we just had lecture on. Sample size, Dr. Neerja just mentioned about that. Words like statistical significance. This is the language of research. So it's good to have them understand the meaning of these words because they will be using it extensively as they go about designing their research. Then framing a research question. So I won't dwell much on it. I think much of it has already been discussed. So one has to address the population, patients, problem, intervention or indicator being studied, comparison group, outcome of interest, and the time frame of the study. All this has to go into consideration when we frame a research question. Then comes the main task, the writing the protocol. I tell you, if you ask me, I will say pay more attention on designing the protocol than later on. Maximum effort should be focused on designing the protocol well. Well begun is half done, you can say. And we all know how to design a protocol. There's a title page, we give a background information, aims and objectives are there, materials and methods, including the inclusion criteria, exclusion criteria, and the methodology to be used. Then we have to mention about how are we going to manage the data and do the statistical analysis. Ethical consideration are of utmost importance. References have to be in order. Informed consent forms have to be there in English as well as in the local language, which is Hindi in our region. Information to patients is to be provided in for proper written form, which we design in English and Hindi. And finally, and the most important, study performer. Study performer has to be designed in a very meticulous manner. It should be designed with much care so that it gathers the pertinent data. The information that the candidate collects is easy to enter on it. It should not be long lines of information, but rather objectively so that yes, no, tick, cross, and the data is collected. And it should be compact. A 10-page non-study performer at times becomes difficult to handle for the students. So guide should pay attention to how to design the study performer. Then organizing the references. We may think that this should come at the end of the thesis. No, it should come right here, because even references are to be mentioned even in the protocol. And it is useful to learn about the citation managers at the beginning of the research process itself. And one can promote citation managers like EndNote and reference manager to organize the references. And usually we are using Vancouver style of references when we are writing in our protocol or the thesis, though there are other styles as well. Then comes the process of ethics review committee. Now, what is an ethics review committee? It's an official body of experts which is constituted to protect the rights and well-being of the research participants. Remember, document of ethical approval is an important official requirement for research involving human participants. And this document is often ignored. You know, it stays with the student. I will always keep it in my safeguard also, because later on, when you move on to publish your research, this is an important document which is required by most of the journals. And Declaration of Helsinki and Belmont Report are the ones which guide the ethical principles for medical research involving human subjects. And these are followed by the Ethics Review Committee. Then comes the top part of registering the trial. If there's a trial, it is good to register the trial under the Clinical Trial Registry of India, CTRI. At MAMC, at my institution, we are doing it for all our PG thesis. Then the course of work. Now that you have got a study approval from the ethics committee, how to go about doing the course of work. And this involves a very efficient planning. Students, I have observed, often struggle to complete coursework of this nature, research, because they have come to become doctors, they have come to become gynecologists, surgery, all this is on their mind. And this thesis is not really in their plan of things that they plan to do. So they often struggle with this. So to help them work past this hurdle, encourage them to break down the project into stages, set goals to reach through the process. So it should be a definite timeline should be drawn right at the outset. Encourage them to set deadlines to work and push them to achieve these. Often the students will need nudging to do their work. Most of us will agree it is more than nudging that we need to get them to do this work. And I will give you an example. Suppose this is my institute. I have a student coming who will be submitting a protocol saying September, October this year. So I expect that in November, I will get an approval of ethics committee. December, January, recruitment of patients and collection of data will start. And maybe in May or June, when I am on vacation, probably I will start them to share with me the review of literature and the methodology to be written. July onwards, when we have some data entered, it needs to be entered into the database, into the Excel file. In fact, it should be an ongoing process. You collect data and keep on entering. And as we collect data collection over a period of year, then starts the analysis over a month or two, and then followed by writing of results and discussion. And in April, we usually have to submit the thesis back to the final draft. So this is a timeline, suppose I draw for my students. I should be sharing with them right at the outside, making it clear that both of us need to follow these timelines with regular updates. So this is a Gantt chart, which which we will follow. We can draw it. These sort of charts are usually drawn for big projects, research proposals, and multi-center studies, so that we all know what deadlines and what timelines we have to follow. And we can always follow it for our thesis, guiding our thesis too. Then proficiency in using Excel. It may sound like very basics, but the students that we get now, even today, many of them are not well versed with Excel at all. Even though it is being taught in schools, but we still get students who are not. So ensure that student is well versed with this. Now, how to do it? So when they come and you know that 6 months, a few months down the line, a protocol has to be sent. Better to tell them that they can hone this skill by online classes, by physical classes, or by practically by entering some data. Some data we have, I will make them sit in my office and they can try their hand under my supervision of entering the data if I have time. Or different ways modalities can be worked out so that they are adept at using Excel. This is an essential tool. Some simple features like freeze pins, data filters are of much use. And I'm surprised that even students who have studied in Delhi and all at times are not able to use these features. And they are with the modern versions of current versions of Excel files, so much can be done with the Excel itself, calculations, simple diagrams, pie charts, bar charts, and all that to represent data. This can be done by Excel itself. Statistical analysis. From my personal experience, I would say we all should know how to do a statistical analysis. Unless we know, we will not be able to encourage our students to do it, and it's never too late to learn this, nor is it very difficult. Encourage the students to learn statistical analysis, understand basic descriptive statistics, tests of significance, which one is to be applied where, on what sort of data, correlations, use of statistical programs, SPSS and Stata. I know how to use SPSS, and this has been of immense use, and I have always encouraged my students, but let me share you, not all of them are willing to learn, but still if we make efforts, at least 1 out of 4 will explore this and will do their analysis themselves, and it will be really equipping them with some good skills at the end of the tenure. Maintain supervision. Now, throughout the course of their thesis, we have to maintain supervision as they navigate through their work. Even the collection of performers and consent form have to be supervised, because they think it is they will just note down some patient parameter or some investigation on a chit of paper, ma'am, we will enter it later. This is not to be done, and unless we maintain supervision, they will not realize the importance of filling the performers correctly, diligently, regularly, and having the consent forms too duly signed by the participants. And when we analyze the raw data, always have a look at their Excel sheets. There will be missing data. There will be some decimal misplaced, and when you apply, see the whole values are one decimal point here or there will throw all the analysis off gear. So you have to pay attention to that. As a guide, have a look at their raw data. And as they begin to draw conclusion about key findings of the research, be with them and see whether they are concluding what they're concluding is correct on the basis of the data and that they have. And then comes the final step of writing the thesis. Now, students need to follow the prescribed format for the thesis. Most of them know, most of the institutions provide them a format or guideline on how to write a thesis. And it is important to use crisp scientific writing. It is not like we are writing a story or a blog. It's after all a scientific writing. So it's important to weed out grammatical and spelling errors, even though the computer does it. But so many times as a guide, when we read, at least I find them very unacceptable to find numerous spelling and grammatical errors, and it shows the shoddy work done on part of the candidate as well as the guide. Provide feedback and edits where necessary on the manuscript. It's very important to go through whatever they have written to see that they are making sense. Pay attention to correctness of references in the text. And I will share this one interesting thing. It's big is always not good. Today, only in today's Times of India, there was a news of a lady from India who did her PhD in biochemistry in 1939. Imagine, before even her parents were born. So it was at that time, and she did her thesis on Cambridge on some enzyme in potato. And in that, her thesis was just 40 pages. And she was a star researcher. So, I mean, making those useless big pie diagrams of, projecting some non-significant information like how many patients were Hindu, how many were Christian, how many were, I mean, this really looks juvenile. So as a guide, it is our job to make them write a good scientific writing, encourage them to write scientifically. And references, often when we get to check the thesis, we realize references are all haphazard. There is no correlation to the number written in the text and the references. So as a guide, it is our job to alert them to these, not to commit any of such errors. And references, as I told, are usually written as Vancouver style, and they have to be well-versed and know what is the correct way of writing references in Vancouver style, be it for a journal article, be it for a book or whatever. Then what, as a guide, we have to tell them is academic honesty. Students need to be sensitized. They have to do the work by itself. And I think once as a guide, if they know you are vigilant, you are monitoring, they will end up doing work by itself. Otherwise, Anything can happen. No fudging of data. This is totally unacceptable. You cannot just fill some random data for the missing values. So this honesty has to be taught to them right at the outset that this is totally unacceptable. Fair and truthful presentation of research material at any forum, be it written or be it in form of a presentation. No plagiarism. No plagiarism. So what is plagiarism? I think we all know, but still copying words and ideas of others and present them as our own. The literal meaning in Latin of this word is so horrible. Kidnapper or abductor. I mean, it's such a bad word. So discuss the issue of plagiarism and its consequences with the students right at the outset when they get allotted to you, when you embark on a research journey. And they have to know that these things can be easily picked up by various softwares and online programs. Who knows, down the years, we may have theses being all checked through these softwares. And no copy paste will work. Now, academic plagiarism can also occur in form of other things which are not very pleasant to say: ghostwriting, honorary authorship, bureaucratic authorship. The students should be made to realize these things are not correct. When somebody else is writing for, you are making claim for some writing which you have not done yourself. Honorary authorship. This word, I call it gifted authorship. It's better that we become, we just don't accept any of such, nor do we give honorary authorship. It's a matter of academic integrity. I mean, it's not like, okay, you write one paper, I write one paper. I have not done any work, you put my name, I put your name. So this sort of a thing, we have all witnessed such things. This should be thoroughly avoided. And lastly, publish the research. So much of effort goes on part of the guide, on part of the student. If they don't publish, this is a wasted effort, just gathering dust in the basements of our libraries. We have to introduce them to the concept of index journals, predatory journals. So what are predatory journals? These are journals where they invite you to publish articles with them. They don't have a proper peer review system, and they will charge you heftily for publications. So I would rather not to publish than to publish in a predatory journals. I know there will be a lot of difference of opinion. I know but there's a lot of literature is there, whether that's correct, what is wrong. But as of now, ethically, it is not good to publish in predatory journals. Challenges when guiding a thesis. Now, this is something, what challenges do we face as a guide when we are taking a student through this journey of research? Students' knowledge. We say look for the lacuna in knowledge. What knowledge do they have of gynaecology that they will look for lacuna in knowledge? This is one question which always comes to my mind, but then this knowledge can be acquired by extensively reading. So if there is some topic of research or thesis that they would like to do or what you have zeroed in, let them read at least 50 to 70 articles related to that. It's only by extensive reading that they will get a concept of knowledge that is available and then find the lacuna in them. So extensive reading is the only way to find what the lacuna in knowledge is, because only when you have a study which is addressing this lacuna that it becomes publishable. Otherwise, it will not become publishable. The students are overburdened with clinical work and hectic duty schedule. You all will agree, and they have to fit it in this. Students have no desire for research. Their aim is not aligned with the course requirement of writing a thesis. They know it is just something which they have to go through with no interest in all that. Unlike, say, in UK, there if you enroll, when they're going through their residency, there is no requirement for research apart from audits. But when they will actually want to do research, they have to take a break from clinical services and they enroll in the PhD program of, say, 3 years where they do exclusive research. So here it is but this is really what I think why the very fact that thesis is incorporated in a PG curriculum is so as to introduce them to the process of research. If they're not at all introduced to this research process, how will they even think of taking it, doing it later in their career? Non-existence of culture of research in the department. This is very dynamics of hierarchy of the guiding department. I mean, as a junior faculty, I realize dynamics, what is my position in my department? Am I being given time to work on some project of my thesis of my student? If I have a research which involves, say, imaging in a department, and that department gives 2 day random days, okay, we give you this slot and these days, and the student has to go there. And my unit can say, no, she can't go on these 2 days. So it depends upon my hierarchy in the department also. And these are constraints which nobody mentions. We just live through them and somehow struggle to get the research completed. A student may be good at clinical work, but not doing thesis work. She's very good otherwise. So these are the things that so this is all that I'm sharing is what I have experienced over so many years. So now, poor language skill, poor computer skill. I have students who have they just have no concept of English grammar. They cannot communicate 5 sentences in English and they have to write a thesis in English. They have probably never handled computer. And we expect them use. They are struggling with their study, with their duties, and with this research, and with no skills altogether. So this is a very big barrier. So what I feel is the moment a student gets enrolled with us, you make this checklist that you have to have these skills, acquire them in a few months that you are available, so that they know they will not be able to do the research without these skills. Now, how to be a good guide. So this is not, and what I feel I am sharing with you, have sound and updated knowledge of that subject. Unless we know what we are talking about, we will not be able to guide the research. Be active in research field. Have a strong publication record. Yourself, unless I have published something, believe me, unless I have written a full-length article, I will never be able to guide my student to write a full-length article. My thought should be given when framing a protocol. This is the most critical moment. If your protocol is well formed, your things will flow smoothly. Have sufficient time to provide adequate supervision. Whatever busy schedules we may have, if we have taken a student for guiding, we have to take out time, a lot of time for guiding that work. Ensure that timeline of research is adhered to. So this is very important. Understand the strengths and weaknesses of the student. They are also like our children, where the way we understand strengths and weaknesses of our own children, as we work closely with them, we realize them, and we have to utilize their strengths and work on their weaknesses. We should be able to provide mentorship and have a supportive personality and not always a critical one. So this is what I have to say and share my thoughts about how to role of guide on research methodology. Thank you very much for your patient listening.
Thank you, Dr. Priti. That was an excellent talk, and really from the heart, with all the experiences that you have encountered over the years, it was coming through very well. And I think you have summarized so beautifully. I agree with you completely that this research, which we do as a thesis in MD or MS, is really speaking just to teach the basics of research methodology to the student and to set the stage for the future. Having said that, it's very important, because they do spend extra time, that it should be something of their interest. So if the student already has an interest in some particular subspecialty, we should try and focus the thesis towards that. And I think it's very important if we can try and build in some lab work or some technique that will give them a little bit of advantage as a hands-on. I would like to share my own experience as a PG student with you. When I joined, and Dr. Vijayalakshmi Bhargav was my guide, and she said, what would you like to work on? And I said, anything related to oncology. I never had any cancer patient or anybody in my family, but somehow I always had a desire. So she found a topic for me. It was a pre-CA 125 days. They were hunting for a tumor marker in ovarian cancer, and they were looking at something called circulating immune complexes. So Dr. Pradeep Seth in virology, when she sent me to him, he said, if you want to do it, it's good, but you will have to do all the samples testing yourself. And I sat there on the bench in that lab and did it. And it really helped me in later years when I set up HPV testing. I became a lab manager better than the people in pathology. And when that hybrid capture was set up, when they had a problem, they would ask me what to do rather than asking the pathologist. And I give credit always to Dr. Seth for having made me sit in the lab and understand how the systems work. So I think it's important to see that the student gets some extra out of it. That is what I would say. I see that there's a couple of questions in the chat box, and you can answer that question, Dr. Deepti. How can QA vigilance minimize scientific misconduct?
Yeah, how can a guide it? So I think it is the most important thing is you have to be with the students. You have to be with the student and supervise what data is collecting, how it is being collected. Scientific misconduct means what? I mean, either you are fudging the data, or you are mishandling your patients, or you are drawing conclusions which should not be drawn. So if as a guide I'm maintaining a supervision, this will not happen. These things only happen when my supervision is lacking. If I'm checking, if they know they have to fill the performer, fill initial ones with me, if they have no, they have to submit. Students leave. Students, they are coming from, say, from Jharkhand, Ranchi or wherever. They will do the thesis and they will leave. I always have their performers collected with me. They have to deposit those performers with me, which most of them I randomly supervise. So that I have a raw data with me, I have the ethical approval with me, and when they want to write, they can always collect with me, because it's very important. You know, they are young girls, they are getting married, they are going away to different states, and this is the hardly thing that they will say to me. So maintaining supervision, maintaining raw data, and seeing how they collect data is the way to prevent scientific misconduct. Any other thoughts that other esteemed faculty members have, I'll be willing to.
Dr. Sunita Mittal has put a question to all of us in the audience. Madam asks, why do research? She has said she would love to receive the views of as many as possible. If you don't wish to answer now, you may send it to her email at sunita.mittal@gmail.com. She has put a comment in the chat box. Thank you, madam.
I will talk to her. She was my mentor. She was when I was in the Lady Harding, I used to be with her. She was my registrar, and she was the one who has taught me breech deliveries and rather proper conduct of all the deliveries. I never forget Sunita Mittal. And Dr. Neerja, do you remember when I had first gone to see you? You don't remember. You were checking the thesis of a PG student. And I was so impressed that she's personally checking each and every line you were checking. So that is how you learned from your PG years and you passed it on and you are passing it on. That's why I always take you as an exemplary person who works by putting in the examples. Now, my question is, what do we expect from the ICMR to give more support to the research in this country? How, Dr. Neerja or Dr. Deepti, how we can improve the research?
Ma'am, research when we apply to ICMR for any project, our research project is screened by a panel of learned people. So our research question, research design, our research protocol should be robust enough to pass through the scrutiny of our experts. Unless this cannot be learned in a day or two. Usually, as we grow up in our stature, we first begin by writing our own thesis, then writing the thesis, and gradually we grow up to writing a research project.
I just wanted to know whether you have expectations from ICMR, from funds allocation or anything where we are lacking.
For thesis, no. For thesis, they don't give, but as individuals,
they do give money for buying kits. My own PGs have got. They do have funds for buying kits in case of some projects like which require to buy some equipment. They give even up to I think 3 lakh rupees for that. So if it's a project, they can apply, and they also have some Kishore Yojana projects for the youngsters which students can apply for.
And where the doctors apply for it from private practice? If somebody wants to do a project, how should they apply?
So there, Dr. Mala Srivastava is the best person to answer that question. She's an extremely successful private practitioner researcher who is involved in the projects of ICMR, and I think Dr. Indrani also was involved before her. So I think it's a culture that is going in Gangaram.
So I got the right person.
Dr. Neerja is still for the thesis. When you want to do the thesis on some medicine or some drug, then ethical committee creates the problems. You cannot use this drug particular, especially for the thesis topic. So how to overcome these problems?
So I think if it is a drug that is already in the market, then that is a simpler problem thing, because we are taking a donation of the drug, but we give a clear statement that they do not have any role in the design of the protocol or in the analysis and the results. So they are just giving the donation. So it is, it is completely de-linked from the protocol. But if they come to us with a protocol and say you do this, then that will meet with ethical concerns.
Dr. Dipti, I make a comment about what Dr. Sunita Malik said, why do research? So I would say research generates evidence. Evidence drives clinical practice. So
because you have
to generate evidence to provide a good clinical practice, and it should be a responsibility of the West alone to generate evidence. So these are, unless we do research, we learn the tools and the methodology of research, we will never be able to, we will just remain consumers of their research and never creators of the evidence.
Very well said, Dr. Dipti. Somebody said this, I heard this from someone else also, that we all believe in practicing evidence-based medicine, but we should not merely be consumers, we should be producers of that evidence also. And also I wanted to add to what you said about publishing the paper. Somebody even said that it is actually unethical not to publish the results of your research, because
absolutely
who participated, gave their time, gave their blood, gave their specimens, hoping that they were contributing to science and contributing to humanity's advancement, and you have not published that work.
Yeah, we should publish each and every thesis.
Publishing is not an easy thing nowadays. All of you, ma'am, who have put it will agree. And first of all, we have to, I think as guys, we have to learn how to write a paper. Actually, you have to spend your own sweat and blood to write a paper and see how difficult it is to go through the peer review process and get it published. And that makes you wiser on how to guide a research, how to frame a question, and how to make a student write a paper.
Yeah, thank you, Dr. Dipti. It was a wonderful and excellent lecture. We really enjoyed, and you really guided well to how to behave as a guide and how to guide your PG. That is a very important thing. You gave the very salient points. Thank you very much.
Thank you.
Articles related to midlife will be welcome in Journal of Midlife Health. Ours is a peer-reviewed and PubMed journal, and on Scopus also. So it has a good reputation. All of you can try and send it, and it is peer-reviewed. So please, I'll be there to help you personally, because that is what I want, more and more research on the topics related to midlife. Thank you very much. Let's move on. We are running short of time.
Dr. Ridhi.
Thank you, Dr. Ruma and Dr. Deepti, for a wonderful
Absolutely
session.
Wonderful. Just one line. Absolutely wonderful presentation by Dr. Deepti. And I'm waiting for Dr. Radhika also, because I had a long time interaction with her, that when I have an opportunity, I'll have a webinar with her.
Now moving on to our second session, I would like to invite the chairpersons, Dr. Ruchika Garg, ma'am. Ma'am is a professor in Department of Obstetric and Gynecology at SN Medical College, Agra, and she is joint editor Journal of SAFOG. Welcome you, ma'am.
Yeah, thank you.
Now I would invite Dr. Harsha Khullar, ma'am. Ma'am is Vice Chairperson and Senior Consultant at Institute of Obstetric and Gynecology at Sir Gangaram Hospital. Welcome you, ma'am. Now I would invite Dr. Sunita Malik, ma'am. Ma'am is Professor, Senior Consultant and Unit Head at Safdarjung Hospital, Delhi. She is also Chairperson, Gynae Oncology Committee, AOGD. Welcome you, ma'am.
So it gives me immense pleasure to introduce our Lakshmi Srikhande ma'am for this very informative talk on evidence-based medicine in Obs Gynae. Lakshmi madam doesn't require any introduction. She's been on so many platforms. She's the chairperson elect for ICOG. She's national correspondent.
You got muted.
Midlife committee our Indian Menopause Society. She's the founder and patron of Isopar Vidarbh chapter, and we can see how fast this Isopar Vidarbh chapter is growing under her leadership. And she's President Association of Medical Women's Wing of Nagpur, and we have attended so many webinars under her guidance. And she's also a recipient of so many awards, including the Bharat Excellence Award, Nagpur Ratan Award, Mehroon, and Best Committee Award was also received under her leadership in 2007. And she has also worked in the field of Save the Girl Child. So I would not come between you and Lakshmi ma'am's deliberation. So over to Lakshmi ma'am.
Thank you so much, Ruchika, for your generous words for me and a wonderful introduction. Very good evening, all the respected teachers, seniors, and dear friends. It's a wonderful webinar where I am also learning so much from all the esteemed experts, and Dr. Mala, Dr. Maninder, you are doing a great job. Thank you so much for making me part of this excellent webinar. So friends, Dr. Mala has given me topic of evidence-based medicine. Are my slides visible? Am I audible?
Yes, yes.
Yes. So first, let us learn what is evidence-based medicine. EBM is nothing but integration of best research evidence with clinical expertise and patient values. So you all can see that all the three components are interlinked. And these three major components are patient, physician, and information. And you can add details to these three components. For patient, it will be values, concern, preferences, expectations. For physician, it is training and experience, current expertise, continued learning, and demand for proof. And when it comes to information, it has to be clinically relevant, proven by research, and best up-to-date evidence. So when I'm talking of these components, are you all not thinking that aren't these just the same old ingredients tossed into a new recipe? The physician is thinking, isn't this the way we have always practiced medicine? And when it comes to information, the doctors are asking when I am supposed to find the time to do all these things. So friends, let us first take a test. So you all join me in taking a test, check whatever applies to you. So my first slide is what is the basis of your medical practice. And you all have to tick mark what is the basis of your medical practice. I have come into this slide sorter view so that you all can see what I am talking. So let us tick. I am waiting for your reply. First is training, clinical experience, and consultation with other professionals, convincing evidence from articles, case reports, product literature. C is preferences of the patient, and D is active research of randomized controlled trials, systematic reviews, and meta-analysis report. So what is the basis of your medical practice? If you have ticked A, excellent. But past knowledge and practice might be outdated or inadequate. And I hope you all agree with me. So now let us go to the first question again. And if this time you all have ticked B, then remember the evidence may be biased, outdated, incorrect, or not applicable to your patients. So let us go back again to my first question. And this time, if you have clicked C, that is preferences of the patient, mutual respect, better cooperation, compliance, wonderful. But this is not always an easy task, and conflicts will definitely occur. These are just some of the examples where we always encounter the conflicts when we try to take patients' preferences into account. So, education about current alternatives and risk is often needed, but not only for the doctor, but for the patient as well. an important rule in evidence-based medicine is that it starts with the patient and it ends with the patient. Patient's preferences must be considered, but this cannot be the correct answer. So I'm going back again to my first question. And this time, if you have ticked D, then super. But remember, in the practice of evidence-based medicine, it is the physician's duty to find the best and most current information and apply it judiciously for the benefit of the patient. The practice based exclusively on science and math is effectively only if your patients are robots or clones. So don't forget to allow for individual human differences and personal preferences. So coming back again to my slide, that what is the basis of your medical practice? It has to be all the 4 components which I have mentioned in this slide. Then only you can say that you are doing evidence-based medicine. So what are the steps of evidence-based medicine? Congratulations if you are already doing evidence-based medicine, but some of us who wants to know and who wants to start evidence-based medicine, then the steps are: convert the need for info into an answerable question, track down the best evidence, critically appraise that evidence, integrate the appraisal with one's clinical expertise and the individual patient, evaluate one's effectiveness in executing the first 4 steps, and seek ways of improving one's EBM approach. So in short, you have to first formulate a clinical question, that is ask, acquire, appraise, apply, and assess. This is the evidence-based medicine process. What are the benefits of adopting EBM? It will minimize the errors in patient care, reduce the cost of treatment to the patient. It will optimize the quality of patient care. Skill learned in practicing EBM are the very same ones needed for being a lifelong self-directed learner. We all say we are lifelong a student. Habit of accessing literature on a daily basis is the best guarantor of ensuring advancement of knowledge and keeping abreast of scientific process. But friends, how much is actually being applied to patient care? We all know that evidence is needed on a daily basis, but usually physicians, they don't get it because of lack of time. We have out-of-date textbooks or the disorganization of the up-to-date journals. So the other factors which influence our evidence-based medicine practice is reproducible evidence strategies, overwhelming size of literature, inadequacy of textbooks, difficulty in synthesizing evidence and translating it into practice. There are increased number of RCTs and control trials, and the available computerized databases we have to find and screen and filter is really difficult. But all said and done, a 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. And this is very true for we all. Remember, about half of valid evidence today is out of date in just 5 years. And about half of valid evidence is not implemented because of different settings where we practice. These are various types of studies. I will not go into detail. My first 2 speakers have already told you. But as a clinician, we have to be well versed with these types of study. When we are doing literature search, we should know what is observational study, case controlled, cross-sectional, longitudinal study, experimental study, randomized study, and randomized controlled study. So this is the pyramid, and on top of this pyramid is, of course, the systematic reviews, which has got more weightage when it comes to evidence-based medicine practice. So how to identify the best study? If your type of question is for therapy, then RCT, cohort, case control, case series. If your type of question is for diagnosis, then prospective, blind comparison to a gold standard. If your type of question is etiology, then you can go for RCTs, cohorts, case control, case series. If your type of question is prognosis, then go for cohort, case control, or case series. If your type of question is prevention, then these RCT, cohort, case control, and case series are your answers. Clinical examination is your question, then you have to go for prospective, blind comparison to gold standard studies. And if the cost is there as a question, then economic analysis is the best type of study which you all should take. Now, this level of evidence should be by heart to each and every clinician, to all the postgraduate students, and to all the teachers, because this is how you will be interpreting and applying this level of evidence to your practice. Remember, 1A is systematic reviews, which I already said, it tops the pyramid. 1B is individualized RCTs. 2A is systematic reviews of cohort studies. 2B is individual cohort studies and low quality RCTs. 3A is systemic reviews of case control studies. 3B is case control studies. 4 is case entries and poor quality cohort and case control studies. And level of evidence 5 is just expert opinion, which we say in my opinion, in my experience, but the level of evidence for this statement is level 5. So is EBM needed only for the clinicians? No, there has to be an EBM approach to education as well. And I'm so happy that Dr. Mala is here and she has already incorporated this EBM approach for teaching to her postgraduate students, because medical educators and medical colleges, they have the singular responsibility of indoctrinating the principles of EBM as a concept, as a philosophy, as a religion necessary for being efficient, compassionate, caring, and responsible clinician among the future physicians during their formative years of training. So why we all are having so much sudden interest in EBM? Because the increasing realization among clinicians that years of experience unaccompanied by updating of knowledge can result in decline of clinical performance. The need for valid information about diagnosis, therapy, prognosis, and prevention in this era of consumer activism is very much in need. The common man, remember, has access to the very same medical literature as we clinicians have through numerous sources. There is limited time available to the clinician for acquiring information is a major impediment for updating the knowledge from traditional sources. Aren't we all say in our day-to-day talk that our patients are more learned, more knowledgeable, and when they ask questions, we should be in a position to answer them, and we should give them an up-to-date answer on evidence-based facts. So where do we go for help with decisions when we as a clinician are not sure how to proceed? So these are the decision making. Remember, the decision making is the cognitive process resulting in the selection of a course of action among several alternative possibilities. We all are gynecologists in the audience. That is why I have just posed this query that when it comes to ectopic pregnancy, we are in a dilemma whether to go for medical therapy, laparoscopy, or laparotomy. So this is the decision-making model. Starting from identifying the decision to be made, you have to gather the information, identify the alternatives, weigh the evidence of each alternative, choose from alternatives, take action, and you have to review the decision taken by you, because it is the outcome that matters. On one end, there is a success and other is the failure. What EBM additionally provides to you, apart from success and failure, is the opportunity. Opportunity for change, opportunity for better treatment. So how evidence affects clinician? If you are doing evidence-based medicine, you are happy, you feel that yes, I am the best. If you are doing not following EBM, then you are always under stress. Will the patient recover or not? Will they sue me? What about my reputation? So I'm sure this slide is self-explanatory why we all should follow evidence-based medicine in our day-to-day practice. So there are two different processes to this evidence-based practice. One is clinical practice guidelines, which ICOG is time to time coming out with clinical practice recommendations, and second is evidence-based medicine. What is the difference between these two approaches? Clinical practice guideline is top-down approach. It tells clinicians how to practice and it is favored by the healthcare system. On the other hand, evidence-based medicine is bottom-up approach. It teaches clinicians how to find answers and it is favored by medical educators. So the new definition for clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. So why do we need these clinical practice guidelines? The rationale for these guidelines are that there is worldwide concerns about unexplained variations in clinical practice, rising healthcare cost, exponential growth of information. So the aim of these CPGs are to facilitate more consistent, effective, and efficient practice and improve health outcome for patients. So who needs these guidelines? These are the stakeholders: doctors, nurses, decision makers, patients, and public. So who benefits from these clinical guidelines? You all can see even the researchers, community, funders, policymakers, each and everyone benefits by these clinical practice guidelines. When it comes to developing countries, EBM, we do have certain shortcomings because of the limited resources, because of our limited capacities for CMEs. Our major CMEs are sponsored by the drug companies and they are little more than captive marketing sessions or biased education processes. In developing countries, we have limited access to literature database and we also have limited access to adequate library facilities. I know in each and every medical college there is library, but are all recent journals are available? Do all postgraduate students and teachers have access to up-to-date information is a big question mark. And there is a questionable applicability of articles retrieved, because article describes a treatment which works in one country, but it might not be possible for you to follow that treatment in your country. So this is how we belong to resource poor country. We have to modify what we are taking from the West. Everything that is old is outdated, is not true. Think 100 times before refuting an old time-tested method of treatment. The classic example is vaginal hysterectomy for benign diseases. It is just a surgeon has give me 2 retractor, 2 scissors, 2 clamp, 1 tissue holding forceps, 1 needle holder, and I can do a vaginal hysterectomy in any setup. So the change should not be like this, but the change should be like this. In this 21st century, you all will agree with me that we are drowning in information, but we are starved for knowledge. So to summarize, what is evidence-based medicine? It is nothing but a combination of principles and methods. When put into action, these ensure that medical decisions, guidelines, and policies are based on the current best evidence about the effects of different forms of treatment and healthcare in journal. With respect to medicine, it draws heavily on information from the benefit and risk evaluation. Remember, clinical experience is a very, very important component of evidence-based medicine, because the decision maker needs to look at knowledge from their own clinical experience along with the best evidence from controlled studies and research. Combining clinical experience and controlled studies in the decision-making process is very, very important. without clinical experience, the risk related to a given treatment may end up causing unwanted effects. Patient judgment is the third very important component of EBM. A doctor's decision includes conscious, explicit, and judicious use of the best evidence at the current time, including the patient's experience when deciding how to provide the best possible medical treatment for a given patient at that particular time, at that particular setup. Patient engagement in decision-making process have an important role to play in building new guidelines for treatment principles. And this includes reading, understanding, and acting on health information, working together with clinicians to evaluate and select the right treatment options, and providing feedback on outcomes. Patients can have an active role to play at all levels of evidence-based medicine. So to conclude, friends, medicine is not an exact science, but a science of probability. The challenge to physician is to provide up-to-date medical care. The ultimate goal for clinicians should be to help patients live long, functional, satisfying, and free from pain and symptoms. By adopting the principles of evidence-based medicine, it will be possible for we clinicians to maximize the benefits of scientific research for patient care. So thank you, friends, for your patient hearing. If there are any questions, please put it in the chat box. Thank you so much for your patient hearing.
Thank you, Dr. Lakshmi, for a very crisp presentation on relevance of evidence-based medicine. As we all know that one of the milestones of this thing in the medical milestones was the evidence-based medicine, and it was first published in 1991. So it is not that old. So before that, I think before EBM was formed, the clinical practice relied on the expert advice. Like we were told that every week you give steroids for the fetal lung maturity. And then of course, these evidences, they changed. And I think we have to be thorough with the latest guidelines also. Because then came that now we are giving steroids just if we are going to deliver the patient within 1 week's time. Similarly, that magnesium sulfate came that is for the prevention of that preterm birth. And then it came for the neuroprotection. And then these guidelines keep changing with time. So one has to be thorough with that what is the latest evidence for that particular healthcare. And as we know that evidence-based medicine, it addresses the deficiencies in clinical care and helps in applying and assessing the best available evidence to clinical care decision. And one of the things I just want to add that you have told about the 5 A's, that is ask, acquire, assess, and like that. The 6th A is that to assess in the beginning of the EBM, and then at the last, that is performance at the end of the process, that we should assess the patient whether we are benefited by this or we are not benefited by this. So it was very excellently, I think, told lecture. And Dr. Lakshmi, I congratulate you for that you have simplified in a very good way. Thank you.
Thank you. Thank you.
Lakshmi, I think that was a wonderful presentation.
And I would like to add one thing to it. Like when we are studying any clinical guidelines, and we should also take care of PICO. It's very easy to remember: population, intervention, then comparison and outcome. That means in what population it has been studied. Suppose if we are studying in a post-menopausal women, then intervention. What intervention has been taken, like what HRT we are giving. Then comparison. Then we will make a different group that there is where no HRT is given. Then outcome, whether the risk of breast cancer is there. So PICO question, if it is, that means the systematic review of randomized controlled trials. They are the best evidence as told by Lakshmi Madam also. And second, we have individual RCTs, they hold their significance. Then we have systematic review of cohort studies, they rank in their significance. After that, we have individual studies, which are in the individual cohort studies, and then case control studies, and they are case series individual, they are lacking in evidence. So very well presentation. So the purpose of EBM is, and what we have to incorporate in EBM, not only the literature which is available, but also the clinical expertise of the doctor and the patient values and the patient preferences also has to be taken into account, because each patient is different. Individualization is also important, because what are the patient values in that particular case. So nowadays we know that 20,000 annually articles, 2 million articles annually are released into the circulation, and the patients are also demanding the IT sector. So much technical hub is being created, and so a very well presentation. This is the thing which I wanted to add. But that
Lakshmi ma'am, there is a question also regarding limited access to articles. Most of the journals are having subscription. So Ruma has asked, what are your thoughts? How should young researchers overcome this problem regarding heavy subscriptions at times?
Of course,
what are your comments? Yeah.
For a middle income country like India, we have limited resources. We don't have funds for the research, but also the maintenance of websites, that is difficult. And for every indexing agencies, they are asking money. Suppose if we want impact factor, SCI, if we want to just apply for that agency getting indexing, they are asking for hefty amounts for that. And for printing charges, we have to keep persons who will sort out the things. That's why a minimal charge has to be paid, either if it is by society or if any pharma company is sponsoring, then it's okay. Otherwise, the charge has to be borne by the author who is there. That is the reason. And moreover, in foreign countries, it has become a business also. But knowledge should not be sold.
Yes.
That is fine.
Up to date and American journals, usually they are heavily subscribed. Yes, definitely that is an
subscription. A very heavy subscription.
Lakshmi?
Yes,
I think, Lakshmi, that was a wonderful presentation.
Thank you.
The only thing I congratulate ICOG also for coming out with the guidelines so frequently, because they are helping a lot for the clinicians who don't have time to go and study on their own. So that is very important. And this era of medical legal issues, at least what is the status of, Lakshmi? I wanted to know about the ICOG guidelines. Can they quote them in the court of law?
No, we differ from RCOG Maninder, because ICOG comes out with guidelines. Yes, you can quote, but I don't know how.
They are actually recommendations only.
They are only recommendations. Yes.
Yeah. So they are not guidelines. So what I was proposing was, like, the researchers, they cannot approach all these journals and everything, that ICOG should make them available for these who can go and approach them and write to them, please, can you get this article for that? Because we have lots of funds, and if we don't have funds, at least we should utilize pharma funds for the research purposes only now. So judicious use of pharma funds, not for the conferences, but for the research purposes should be done. I think ICOG, when you are coming into as a chairperson next year, Lakshmi, perhaps you can look into these angles also.
Yes, a very well point brought about by ma'am. In RSSDI, in medicine bodies are there, like Research Society of Diabetes. They have a special fund. You can apply your proposal there and they will fund you. So this way they are helping.
Not even funds, but they can just give us the link to those articles which we want to see. That can be bought by ICOG for general doctors even. Yeah, you can subscribe to some of the journals for the FOGSIans or for the members of ICOG. Whatever can be done, different associations can help their members if they want to go and find out some evidence is there.
Point well taken, Maninder. I will definitely look into it here.
Okay, thank you. Let's move ahead.
Now we invite Dr. A.G. Radhika. She is a senior consultant, UCMS and GTB hospitals. She has number of positions to her credit and has won many awards, including WHO Fellow in 2011. She has published nearly 75 publications in national and international journals and has edited 2 books also. Dr. Radhika, please.
Thank you so much, Madam, for the kind words. So while I am getting my slides on, I just wish to answer 2 points which were getting discussed just now. Why are the ICOG guidelines not quotable? The reason is these guidelines are not formulated through the globally accepted standards of guideline development. And incidentally, I am just happy to introduce to all of you that I am currently undergoing training through the McMaster University at Canada, the InGuides training program, which is the international accreditation for guideline development. And while I'm going through the various steps, I'm also eligible to undertake training programs. And this I had also got in touch with ICOG. I had spoken to Dr. Ashok for my interest to undertake training programs. I think during the course of discussions, there was some confusion and probably nothing came out. So I think I'll be happy to get in touch with Dr. Lakshmi and be able to come out with my proposal, and we can formulate a model for training, because I'm very keen that we in India have our own guidelines and we are able to, translate that into practice. So that doesn't mean that we develop our own. We can even adopt a guideline which is in existence to have a contextual translation to practice. So with that, I am happy to talk on the basics of meta-analysis. So we have had heavy-duty talks till now. I'm going to have my talk very brief and keep it very simple, so that, because it is just a kind of a teaser as to what is a systematic review and meta-analysis. Henceforth, I would be calling it SRMA. How does one read an SRMA, and what are the aspects of a well-conducted SRMA? Now, there is a lot of information that is available in the literature, especially with the availability of the digital media. We are overwhelmed with the information. So how does a clinician collate all that information? So the best is to have a review. The review has to be comprehensive and it has to be unbiased. And now we have 2 types of reviews which are standard, that is the narrative and the systematic review. So the narrative review is generally undertaken by the content expert, somebody who's got experience in the field on a specific topic. It is a comprehensive overview of the topic by a content expert, like I said. And however, it does not report on how the search for the literature was done and how the inclusion for relevant studies was decided, whether these included studies were critically appraised or not. And therefore, it is not reproducible and there is high level of bias. Because the basic difference is there is no protocol. Somebody just sits, does a literature search, and then produces a review. Whereas a systematic review is a review of clearly formulated questions that use a systematic and explicit method to identify and select and critically appraise the research and to collect and analyze the data from these studies that got included in the review. So it starts with the formulation of a protocol. The protocol can be published at various fora as well as the databases. These could be peer reviewed, and then the systematic reviews conducted, and therefore it is structured and it is reproducible. Thereby there is a reduction in the bias, and it also explores the variability and methods between the study. So the erstwhile speakers, they had also said whether they, you have a clinical question and you undertake these systematic reviews, or you go through these systematic reviews to answer your question. Does it really happen so? See, what I have in India may not be there in the UK or in other parts of Europe or Western world. So would my question get answered with a systematic review or meta-analysis? So it is very important to know the research question and how to translate that into practice. And that is why these guidelines, contextual guidelines, are so very important, because that would be a filter of these systematic reviews and meta-analysis. So since we are now going to stick to meta-analysis, I will be talking specifically about what is meta-analysis. It is a statistical technique for combining the findings from different studies. It combines data from 3 or more RCTs or observational studies, meaning it has to be the same type of study design. You can't have apples and oranges being mixed. Either it is an RCT or it is an observational study, and they are addressing the same outcome. You can't combine a pain outcome with a bleeding. So composite outcomes, there is a different kind of a challenging scenario. So the meta-analysis there changes. I am talking about the bare basics, the brief. So the meta-analysis provides a quantitative estimate of the treatment effect or the diagnostic effect. Now we have meta-analysis even for diagnostic modalities. And it gives due weightage to the size and precision of the included studies. How this is done, I will just talk about in the next few slides. A large sample size and more events, it improves the precision and thereby also reduces the size of the confidence interval. Why that is important, again, we will see in the next few slides. And it identifies the sources of variability and diversity. So if there is a mixture of people, if there is old, young, adolescent, newborn, so there is a huge diversity in the population. That results in the outcome, the precision, as well as the quality of the outcome that one analyzes. So meta-analysis helps us to identify these, and these could be the patient types, the settings, the reasons for these kind of variability and diversities are many, and these are types of about 6 or 7 types of biases that exist, which are identified by the meta-analysis. Now, let us take an example. What are the foods which which are responsible for chronic health conditions, diabetes, hypertension? So if you start, you see here, it starts from 1984, and then you have the latest literature, such a lot of it. How does a single individual arrive at the final answer? So these answers, either you go through all the literature yourself, or you look at the systematic reviews and meta-analysis. However, it is important to note that these reviews and analysis, even one needs to even critically appraise the systematic reviews. Today, we have the assessing tools to even see whether these systematic reviews have been conducted appropriately. So let's take this example. So there is this scientist B who found 10 studies in which A raised the tissue vitamin X levels by 26 units. And the drug A was compared with drug B. And the meta-analysis, here, this is a kind of a meta-analysis which shows a favorable result. And the conclusion was that the drug A raised the tissue vitamin level by certain, there was a positive effect. Whereas when it was conducted by another researcher, so he also found 10 studies and he found a negative association. So this is just to highlight whether all meta-analysis are a part of a systematic review. So a few years from today, people just undertook meta-analysis and they made this is called as a forest plot, which I'm just going to show in the next few slides. And people just developed these forest plots and demonstrated that, the outcome is positive or negative. Whereas a systematic review is the critical appraisal of these included studies and a final take-home message is given through these diagrammatic representation. So a meta-analysis getting done on its own by itself may not have a great weightage, but when it is combined with a systematic review, then it has got a better standing because it gives you a transparency as to what has been undertaken. So here there are two contradictory results. So one said raised, the other said low. Now, there was the third scientist who conducted a systematic review, and he came across all these 20 studies and identified whether they can be included for the meta-analysis, and they could be included, and finally, the outcome was there was no change at all. So that is why this is just to document and show that if one knows how to read these studies, the systematic reviews, and the meta-analysis, then the take-home message and the translation to practice becomes much easier. And therefore, in the hierarchy of evidence, the systematic reviews and meta-analysis occupy almost the top place. And here the pinnacle is by the guidelines. Why? Because the guidelines are obtained from these systematic reviews and meta-analysis. So where the systematic reviews and meta-analysis don't exist, we have the RCTs and the non-RCTs and the prospective cohort trials, which are included for the guidelines. And accordingly, the strength of evidence falls. Now, today we also have something called the grade to grade the kind of evidence that you have. And this has been again developed by McMaster University. It has been universally accepted, but I'm not going to talk about grade. In fact, I would request Dr. Maninder, Dr. Lakshmi, Dr. Mala to consider having a 2-hour session for each of these topics so that we are able to familiarize our gynecologists with these kind of important basic facts about evidence-based medicine and guideline development. And like I said, it's time that we have our own guidelines. So the important fact is that the bias decreases from expert opinion here to the RCTs as well as the systematic reviews and the well-developed clinical practice guidelines. So this is the forest plot. It gives a graphical display of the findings from meta-analysis. It provides essential information to inform about the interpretation of the results. And it basically has 6 columns. Okay, each of these columns we will go through quickly. So the general appearance of these is the forest plot is like this. Why it is called a forest plot? Each of these is like a tree. And there is a central line, which is the line of no effect. So what you have is the first column. These are the studies. Here you have the name of the author and the year, chronological. It could be, the arrangement of these names could be based on the alphabetical or the chronological order. It could even be based on the sample size. Then coming to the next one, here you have the intervention and the control group. The small n is the total number of patients having an outcome of interest, that is the events, and n is the total number of patients who are present in that group. So if you were to see here, Rawling et al., year 2000, in the intervention group, one patient had event out of 131 number, and in the control group, 2 events happened out of 133 women, 133 people. So basically, this is the intervention in the control group and the small n and the capital N. Then we have the forest plot that we just saw in the last few slides. Now here each study is represented by a square and the whiskers. As you can see here, the 2 whiskers which are there. Now before we discuss that, we come to this line. This is the line of no effect. Now if it is a ratio, if it is a study which addresses binary outcomes, yes and no, death or no death. If there is, if the result is plus or minus, it is binary. If it is numerical, increasing numbers, falling numbers, rise in the amount of hemoglobin, increase in the pain quotient, increase in the amount of bleeding, then it is continuous variable. So if it is a ratio, then the line of no effect is 1. And if it is a numerical number, then it is 0. So for continuous outcomes, the line of no effect is 0, whereas for binary outcomes, it is 1. So the square basically indicates the type of study. The size of the square, here you can find this is larger, this is small, because this gives the weightage to the study. Now, what is the weightage to the study? Where you find that on critical appraisal, the quality of the study is good. When is the quality of study good? When the methodologically it is sound, the sample size is more, and the variability is less, meaning the confidence interval is small. As you can find here, the weightage here is much more. The size of the square is more, and the whiskers of the confidence interval are small. So when you have this kind of a outcome, then the study is of a good quality. How do you assess these studies? There are checklists which are available, and they are basically each study is critically appraised using those checklists. So this is the basically the squares, and then the diamond is the final pooled result. So you see the size of the diamond, and if it is hitting the point of the point of no effect, if the squares or the confidence interval or the diamond hits the line of no effect, that means the conclusion is not significant. And if it is away either to the right or the left, then the outcome is significant. Now you need to carefully see which side favors the outcome, favors the intervention. So if the left favors the intervention, that means the intervention, whatever has been the drug or the injection or the diagnostic test, is favorable, is more favorably poised compared to the control. So that is how one reads this graph. And this we already have talked about the line of no effect. Now this is what Dr. Khullar was also talking about the use of corticosteroids. Now it is also important to see that a meta-analysis tells you when the results are conclusively drawn. We had these results about the benefits of corticosteroids very much before we started actually getting it translated into practice, as Dr. Khullar very rightly said. And the reason was people got, they kept on replicating the same research again and again, and they started trying to reinvent the wheel. So meta-analysis tells you when the final conclusion is already obtained. So if the final take-home pool is already on one side, that means the final answer to the clinical queries already there. No more further research is required. So the weightage of the study is given in percentage. And as we have already understood that the weight of the study depends on the sample size as well as the confidence interval. So the ratios are there for the binary outcome, and the weighted mean difference is there for the continuous outcomes. And the line of no effect accordingly is either 0 or it is 1. So there is something which is important. We need to understand what is heterogeneity. I did discuss about the variability of the study. There could be clinical heterogeneity, meaning there could be variability in the participants, treatments, and the outcomes. There could be methodological heterogeneity, meaning variability in the study design and the risk of bias. Each one of these has to be described. I'm not going to do that. It is just familiarity. For the sake of familiarity, I'm mentioning these terms. Then there could be statistical heterogeneity, variability in the treatment effects being evaluated, the kind of analysis that one uses. And because of this heterogeneity, there could be a change in the type of results that one finally identifies in meta-analysis. And this is given by the scores which are done by the I-square test. This is called the I-square test. And here you have something called the tau as well as the p-value. So the heterogeneity is done by estimation of the heterogeneity is done by overlap of the included studies and the point estimates in the 95% confidence interval. So as we found in the earlier slides as well as here, if all the confidence interval are on one side and if majority of them are away from the line of no effect, that means it is a good study. However, if there is confidence interval hitting the point of the line of no effect, but they are all on one side, that means the heterogeneity is low. The conclusion might be something different, meaning what is the weightage of these studies to give a final conclusion. So this is given by the p-value, and again p less than or equal to 0.05 is considered significant. So heterogeneity, if it is less than or 0.05 is considered to be low. And this is further confirmed with the I-square test. And all these results are given here. So whenever you read the meta-analysis, it is always important to look at these values. Look at the p-value and look at the I-square value. So I-square value, 0 to 40% is not important. 75 to 100% is considerable heterogeneity. So I-square less than 25%, the studies are considered homogeneous. So the calculation, these are fixed in random effect model. I am not going to talk about them now, but it is important for us to know there is something called heterogeneity, which can affect the outcome of meta-analysis. And therefore, it is important for us to look at the baseline values. And I-square more than 75% is a heterogeneous, there is presence of heterogeneity. So it is important to use the right model for analysis of the systematic review. And lastly, we understood the advantages of a meta-analysis. It identifies the heterogeneity, it gives a pooled result, and it also, one of the biggest disadvantages of a forest plot is that it doesn't give you something called a publication bias. So while heterogeneity and pooled results are well displayed, this is something called the funnel plot. So what we see is, here you have the results which have got a favorable effect outcome of that research. And this is, for example, an unfavorable effect. Now, we all know that studies which do not show a significant positive outcome do not find place for publication. Similarly, the ones which are of not good quality may not be published. So if one finds that this area is empty, that means the publication bias exists. So good number of studies which should have been here are not there. So to that extent, the meta-analysis and the calculation gets affected. So this is called as a funnel plot. The publication bias is assessed through the funnel plot or through something called the aegis analysis. So again, it is important. So whenever you read a meta-analysis, always look at the funnel plot to see if there is a publication bias. Languages are important. If I do it was spoken about doing, all those kind of research studies as well as a PG thesis. If I do not have the right kind of a keyword for search, and if I'm restricting my search to only English, so the Spanish, Hindi, Tamil, Telugu, other languages, the publications, I am not able to access them if I'm undertaking a systematic review. So there is a huge publication bias. So one has to be aware of that. So how to draw? So you have the software Revman, which is now freely available for us from the Cochrane website. So I don't think time permits for me to demonstrate how it is done. It can also be done with the Excel sheet. I think we can do it. So this was a video that I had prepared. We'll go through in the next presentation, I think. So why, to conclude, why do we want a systematic review and meta-analysis? Because meta-analysis provides a good quantitative overview of the subject. It estimates the size and weight of the effect and identifies critical confounders and moderators, which is not evident from a single study. And also, these systematic reviews might actually fit your PICO. So always look at the PICO and look at the PICO of the systematic review and see whether it fits into your scheme of things. So today, PubMed search allows you to do a PICO search. So how to do that is also very interesting, another tutorial required. And it also, the meta-analysis also informs you about the design of the new search that you want to formulate and undertake at a future time. So it gives you a chance to do a prospective power calculation as well as a sample size calculation for your study, and the experimental design parameters for your future studies are also answered to a large extent. So thank you so much for your patient hearing.
Thank you, Dr. Radhika. It was really very well explained, how to do the meta-analysis, how to read the forest plot. So many people, they don't know how to read it and how to apply in clinical practice. That's very important. And you have very nicely explained the narrative versus systematic review, meta-analysis, the heterogeneity part, how to go about it and all those. This is very important. So I think there was one or two questions which you need to answer. Let me just read it. What variables need to be inputted to determine the heterogeneity?
So like I said, there could be clinical, methodological, statistical. Each of those will have a list of things to be identified.
Yeah.
So like I said, that will require quite a degree of discussion and all that. So we'll leave it for another.
That's right. It's very a big topic and need to be explained. Just to summarize, I would just say
there is another question. One more question is there, Sunita.
Yeah, what variables apart from sample size need to be inputted to determine weight of the study?
Yeah, so Ruma, all those things. Yeah, so all those things that you had presented, the concealment, when you start assessing, critically appraising randomized controlled trials. So I'm sure everybody knows about the consort checklist, the Prisma checklist. There are so many checklists now today which are available, which allows you to critically appraise these studies. So there are about 7 biases which need to be assessed whenever you critically appraise these studies. So other than concealment, blinding, the methodological other aspects, for example, hemoglobin, if somebody measures with HemoQ, somebody is doing a Sally's method. So many things like that, So we need to critically appraise and see the value of each before we start combining those.
I may come in just for a second. So
certainly, sure.
Give the example of hemoglobin, the kind of heterogeneity you accord to that variable. This is researcher determined, or will it be determined by the software?
No. So as a researcher, as a person who is critically appraising the study, it is for me to identify that. I know the sensitivity of HemoQ is very different from Sally's. So a person, a large community trial, for example, okay, of a effect of a drug. So somebody compares ferrous citrate with ferrous sulfate. So the person has assessed it with HemoQ and Sally's. So there are two confounders, the drug as well as the diagnostic technique. So I, as a person who is critically appraising it, will now have to grade it. So there is where that grade comes, And now I'll have
That's
to see.
what needs to be written, yeah.
Yeah. So so there are many subtleties.
Yeah. So just to summarize, for meta-analysis, we need to frame a question, proper question. What do we want to analyze? Research on PubMed, Medline, so many sources are there. Read the title, abstract of the individual papers, abstract information from the selected set of final articles, and then determine the quality of the information in those articles. This is done using a judgment of internal validity, but also using the grade criteria, which you just mentioned. Determine the extent to which these articles are heterogeneous estimate the summary effect size in form of odds ratio using both fixed and random effects models, and construct the forest plot. Then, of course, determine the extent to which these articles have publication bias, which you have all nicely explained in a funnel plot. And finally, conduct subgroup analysis and media regression to test if these are subsets of research that capture the summary effects. So that's in gist about meta-analysis.
Thank you so much. I think that really was a nutshell. Absolutely brilliant. But I just wish to conclude by saying it's not a good idea to undertake only the meta-analysis.
Yeah, of course.
It's always a good idea to combine systematic review with
Systematic
meta-analysis.
reviews, yeah. Meta-analysis may not be part of that.
One
That's
question, Dr. Radhika.
Yes.
One question.
Yes.
What is Scopus reviews?
Scopus is another agent. Now we have databases. Like we have the Thomson Reuters, then we have Scopus, then now we have Web of Science, ISI. So there are various types of agencies which are indexing agencies. And you have these reviews which could be put forth by these agencies, which has been conducted by them. So, and in case you are asking about scoping review, that is something different. So the systematic reviews could be of various types. There could be scoping review, mapping review. There are various kinds of reviews. There are about 12 types of reviews which are available today. There could be even rapid reviews. Each has its own methodological difference. So I have broadly given a gist about what is a systematic review. So a rapid review, for instance, if I want to undertake, if I don't have that kind of time, COVID was full of rapid reviews because it was a new situation. We didn't have evidence. We didn't have past experience. So they were living reviews, which were rapid reviews. They conducted them very fast and kept on updating their sites. So scoping review, you give a broad scope to the subject that you wish to analyze, to basically approach, and then define those and define your methodological deficiencies and strengths and proceed with the protocol. So there are ifs and buts for each of these reviews. So I think, again, it takes time. Yeah.
Dr. Radhika, wonderful work done. And I promise you we'll be having more webinars. Dr. Mala Srivastava, it's your duty now to have on each topic one webinar of 1.5 to 2 hours, because that is the only way we can reach out to people. Otherwise, it's very difficult to understand. It goes above my head also. I'll be very truthful.
Yeah, it should be
I'm
a
really
series.
grateful.
It can't be one webinar. No, it has to be a series, weekly series or whatever
Ruchika,
you.
I agree with you.
I am so glad.
Definitely, ma'am. It is in-depth understanding.
I'm so glad to see Dr. Lakshmi nodding and Dr. Maninder encouraging us, and Dr. Mala also smiling and saying yes. So we want these 3 strong pillars to get the job going, So it would be a pleasure to join you.
Radhika, I know about your passion for this thing. I think 3-4 years we had met on some platform, and I had promised you that if I can have a status, then I will do the research. Now I got the opportunity, so I am working on research methodology.
That's really nice, madam. I would be most happy.
Thank you.
So I conclude the session, by thanking Dr. Maninder and Dr. Mala for inviting us over. So over to you, Dr. Riddhi, for next session.
Ma'am, I would request Dr. Asha Rao, ma'am, if she has any expert opinion.
Talks were dealt very nicely.
Yes.
So congratulations. If you shorten the duration of the talk, I think, maybe not much will be delivered. So we have to have a compromise. But I'm very glad that Dr. Maninder and Mala have taken this initiative. Congratulations.
Thank you. Thank you.
Thank you, ma'am. Now moving on to our third session, I would like to invite the chairperson, Dr. Anita Rajoria, ma'am. Ma'am is Head of Department, Senior Consultant, Department of Obstetric and Gynecology at Dr. Hedgewar Arogya Sansthan, Government of Delhi. And also ma'am is Founder, Vice President, Delhi Gynae Forum, Southwest. We welcome you, ma'am. Now I would invite Dr. Rahul Modi. Sir is a Consultant, Division of Gynae Oncology at Sir Gangaram Hospital. Welcome you, sir. Now I would invite Dr. Rakhi Singh. Ma'am is Director at Abalon Clinic, Maternity, Fertility and IVF Center in Noida. Welcome you, ma'am. Now I would invite Dr. Mala Srivastava, ma'am. Ma'am is Senior Consultant and Professor at Sir Gangaram Hospital with special interest in gynae oncology, gynae endoscopy and robotic surgery. Ma'am is Vice President-elect ISOPAP 2023-24.
First of all, I must congratulate Maninder ma'am and Dr. Mala for this very well organized webinar on research methodology. And it is a very well thought of topic, and we all need to learn everything about it. Now we have framed a very good research question. We have done a beautiful study. We have generated a lot of data. Now what to do with that data? So we are going to analyze, and how do we do it is statistics. Statistics is nothing but the science and art of dealing with numbers. It is used for collection, summarization, presentation, and how to analyze that data we have collected. And then we get unbiased information based on the data we have collected. So to talk about this, how to use it and how to interpret the results, we have none other than Dr. Satish Chaluja, who will be talking on basics of medical statistics. Sir is the co-chairperson, senior consultant, Department of Neonatology at Center for Childhood at Sir Ganga Ram Hospital, Rajendra Nagar. He has held several positions: Secretary, National Neonatology Forum India, Joint Secretary, National Neonatology Forum, and then Secretary, National Neonatology Forum in 2005 and 6. So over to you, sir. We are eager to listen to your presentation.
Thank you, Dr. Anita, for a lovely introduction. And at the outset, I would like to thank Dr. Mala for taking this initiative and allowing me to be here among such learned obstetricians. And I'm the odd man out. I think I'm the only neonatologist on this panel discussion. And after listening to wonderful talks over the last couple of hours, and especially the one on systematic review and meta-analysis, to talk about basics of medical statistics appears very trivial. But still, I will try to take this topic, and the topic which has been given to me is basics of medical statistics. So I will not get into very detailed statistics. More often, the doctors, whether they are doing thesis or into research, they do not perform statistical analysis themselves. They would take their Excel sheet to a statistician, give it to the statistician, and statistician will do some statistical test on them, take out some p-values, and at the end of it, if no p-value is significant, the researcher becomes very depressed. Sir, ek bhi p-value significant nahi aayi, kuch to kar do iska. But I think what we have to understand is that we have to understand methodological aspects of what we have done and in what format we have collected the data, and then frame certain questions that what kind of answers I'm looking for from my data. Then only we should initiate our statistical analysis, and then only we'll be able to understand that what we are trying to do, and we will learn how to do them. The objectives of this presentation is what is the role of statistics in medicine, and the purpose is to analyze, interpret, and present your results. So most importantly, as we have been discussing in the last couple of hours, that we should be able to understand our research question. Amongst the research question, what is the population we are looking at? What is the intervention, if there is a comparison group, and what are the outcome measures? And we are trying to find answers which are related to the outcomes which I have taken out from my study. What have been the objectives? My statistical analysis should be such that I'm able to answer my research question based on my objectives. And of course, I should be very clear about study design, as Ruma was talking about. My statistical analysis planning will be based on what study design I followed for my to answer my research question. And of course, I need to understand a bit about something about my variables I collected, which one was the exposure variable and which one was the outcome variable. I'll come to that in little more details in subsequent slides. Then I choose appropriate tests. And then once I apply those tests, I come out with some output. I should be able to interpret that output and also try to find out what is the statistical significance of those results, which commonly are talked about in terms of p-values and 95% confidence intervals. So I'll just touch some of these things in subsequent slides. What are the types of data and variables? That's the most important thing. So I said there are two kinds of variables, the exposure variables and the outcome variables. The exposure variables could be risk factors, and they're often called independent variables. They are often used to make groups. For example, if I say my exposure variable is birth weight, it could be low birth weight, normal birth weight, very low birth weight. It could be exposure to any risk factors, something like smokers and non-smokers, and other risk factors like diabetes, hypertension, preeclampsia, abnormal Doppler flows. So these could be my exposure variables. And the outcome variable are also called the dependent variables. For example, presence of lung cancer, which is an outcome among smokers, and I could compare it amongst non-smokers. Neurodevelopment at some point of time after birth in neonates who were either born normal birth weight or were born low birth weight. Another outcome variable could be mortality, maternal, fetal, or neonatal outcomes in women with certain risk factors. For example, if I take pregnancies which had fetal growth restriction, the other group did not have fetal growth restrictions, I could take outcomes as stillbirths, which is in utero mortality. I could look at other maternal outcomes, the delivery outcomes, fetal outcomes, or neonatal outcomes at the time of birth or subsequently. So I have to be very clear in my mind that what are my predicting variables or the risk factors, what are the exposure variables, and what are the outcome variables. Then there are two types of important variables. One is what are called continuous variables, which are also known as quantitative variables. It means any variable which is measurable, for example, birth weight, blood pressure, serum cholesterol, I can measure them. So they are continuous and they can be any number. And the other type of variables are categorical, which I can frame into certain categories. For example, gender. Gender can be two categories, male or female, or ambiguous or unknown gender. But gender cannot be 1.5 male or 2 male, so it can never be a continuous variable. Then staging of cancers, stage 1, stage 2, stage 3, stage 4. So these are again categories of my outcome variables. So these are called qualitative variables. I'll not get into nominal and ordinal kind of variables. A few examples of quantitative or continuous variables. Weight could be in kilograms, it could be in grams. So we have to specify that what kind of unit. And mind you, for all patients, the data should be recorded in the same units. It's not that you have 100 odd babies. Of 90 babies who have weight in kilograms, and in 10 babies you have recorded the weight in grams. So that will cause disparity and you will not be able to analyze your data well. Blood pressure in millimeters of mercury. Duration of stay in days, duration of mechanical ventilation in days. Similarly, if I take examples of categorical, they could be either two categories. For example, mortality, a baby will either die or survives. There could be yes or no answer to an outcome. For example, wound infection, yes or no. There could be more than two categories. For example, the survival outcome could be died, survived, or LAMA. The clinical sepsis could be, amongst sepsis would be clinical sepsis, culture negative sepsis, or culture positive sepsis, and staging of carcinoma I've already talked about. Then comes, we need to frame questions to our data, to which we are trying to find answers from our statistical analysis. I'll give you certain examples. So first, I'm clear that what are my predictor variables, which are independent. For example, BP, hypertension, sex, smoking, obesity. Is this a quantitative variable or qualitative variable? I have to find that out. For example, blood pressure is a continuous variable. Hypertension is a categorical variable because answer would be yes or no. Gender, smoking, obesity I've talked about. What is my outcome variable? So these examples I've already talked about. For example, developmental quotient, which could be normal or abnormal. I could also take developmental quotient as a continuous variable. So I can have the same variable in two formats. My DQ could be 65, 66, 75, 95. That's the continuous variable. My DQ could be normal or abnormal, which is less than 85 is abnormal and more than 85 is normal. So I'll have to define those variables in that fashion. So that is the first question I want to ask from my data. Then I ask myself, am I trying to estimate something? So I would need descriptive stats for that. Or I'm trying to compare something. So when I look at descriptive statistics, we talk about for continuous variables, either means or medians, which I'll come to. And for categorical variables, we talk about proportions as we report in prevalence or incidence studies. The other question I asked is, are we comparing something which is comparative statistics? Are we comparing means? Are we comparing proportions? Are we comparing in two groups? Are we comparing more than two groups? An example could be, for example, comparison in two groups. Comparison of proportions in two groups or more than two groups. For example, mortality or developmental quotient categories. Comparison of means in two or more than two groups. For example, mean duration of hospital stay, or comparison of exact value of developmental quotient. So these kind of questions I should be asking from my data before I start my basic analysis. We'll take examples of descriptive statistics. If I have a variable with quantitative data, first thing I should do is I should check the distribution of my data, whether this is normally distributed or the data is skewed. If the data is normally distributed, I should report mean and standard deviations. And if my data is non-normally distributed or skewed, then I should report median or IQRs. For example, mean age in two groups of patient was with a mean of 32.4 years plus minus 5.8, which is the standard deviation. And in the other group, the mean age was 36.7 years with a days or years 8.56. For a skewed data, we report median and interquartile range. Interquartile range is the first commonly reported as first and third quartile. So I would say the median duration of hospital stay in two groups was median of 30 and IQR of 21 and 45 days as compared to 25 median in the other group with the interquartile range of 11 and 35. Then we come to how do we talk about descriptive statistics for qualitative data, and we report them as proportions. For example, gender. In a population, we had 32% males and 68% females. The mortality in two groups where some intervention was done was 30% versus 22%. So that is, we can either report them as percentages or we can report them as proportions. Like 30% and 22% would be in proportions would be like 0.3 and 0.22. Then we come to comparative statistics. I'll just give you a gist that what test to apply under what circumstances without getting into complicated statistical analysis. I'll talk about very simple statistics which we as clinicians, we as doctors should know, and we perform them on day-to-day basis. So I said we have two types of data, quantitative data and qualitative data. Let me see what tests to apply amongst qualitative data. Parametric tests are done if the distribution of continuous variable is normal, Gaussian distribution. And non-parametric tests are done if the data is skewed. If we have a one group, then one sample t-test is done. And in one group, if there are paired observations, we would do a paired t-test. If we have two groups, then we do a student t-test. And if we have more than two groups, then we apply a test which is called ANOVA. Amongst non-parametric tests in one group, we do Wilcoxon signed rank test. And for two groups, we commonly call it as Mann-Whitney U test, but it is also called Wilcoxon rank sum test. And for more than two groups, the non-parametric equivalent of ANOVA test is Kruskal-Wallis test. Amongst qualitative data, for independent samples, we use chi-square test or a Fisher-Exact test. Fisher-Exact test is done for small samples where the expected number of events in one of the cells of a 2x2 table is less than 5. Otherwise, commonly for a reasonably larger samples, we do a chi-square test. And for matched samples, we do McNamara test. Now, let me take some examples how to go about performing basic statistics. We explore data. We know what are means, median, standard deviation, distribution, and skewness, report percentages and proportions. And these are commonly done on certain statistical softwares. I'll give you an example of an output of SPSS, where DQ at 18 years in children born either normal birth weight or low birth weight were compared. So this is a exploration of a quantitative data on SPSS. If you look at on the left side, the outcome variable is DQ. There are two groups, low birth weight and normal birth weight. And you can see the mean DQ in low birth weight is 79.91 with a median of 88, standard deviation of 19.7, and the skewness of minus 0.226, which is acceptable. Any skewness which is less than 1 tells me that my data is normally distributed. And similarly, the lower half gives me the details of normal birth weight. So if I was to compare the mean DQ in low birth weight and normal birth weight, which is 79.9 versus 87.2, I'm looking for the difference of 7.3 DQ in these two populations. And I want to know that this difference of 7.3, which was observed in my data on developmental quotients, was statistically significant or not. So what do? I apply student t-test. And this is the output on SPSS, which I get from the student t-test, which is also called independent sample test. And I find that my p-value is 0.407, which is not significant. Just look at the 95% confidence interval. I'll talk about it a little later. The lower one is negative and the upper one is positive. We'll discuss how to interpret these a little later. Then comes comparing categorical variables. And what test we discussed for qualitative data, we said chi-square test. So if the question from my data is that what is the difference in developmental quotient at 2 years in babies born low birth weight or normal birth weight? So here I have categorized my developmental quotient into normal and abnormal. Is this difference statistically significant? We could also calculate odds ratios and relative risk. I'll not go into that. And the test to be used is chi-square test. This is the output which I get for the chi-square test on SPSS. If I look at this 2x2 table, the rows are low birth weight, normal birth weight, and the columns are normal DQ and abnormal DQ. So what do I find? Amongst low birth weight, 54.5% of the neonate or children had a normal DQ, whereas amongst normal birth weight neonates, the DQ was normal in 77.8%. So what do I check? Whether this difference of about 23% is statistically significant or not. And when I look at my Pearson chi-square value, this encircled 0.374 is a Fisher exact test, because if I look at these 4 cells, the number of subjects in these cells is very small. And if looking at the p-value, I can say that this difference of 23.3%, even though it appears a significant effect size for my DQ, but this was not statistically significant, possibly because of a small number of subjects in my population. Then finally comes the question that how do we say that my results are statistically significant or not? And the two common measures used are a p-value. Now, p-value of less than 0.05 is traditionally taken as statistically significant. What does it mean? It means that the difference I have observed in my data set is significant, or it is not significant, or it's by chance only in less than 5%. That what is the probability that whatever difference I have observed is not true? And the chance of that probability, if it is less than 5%, I will say that my p-value is significant and my results are significant, and depends on what alpha error you set up. You could do it 5%, then you take p-value less than 0.05 as a statistically significant p-value. You could put it as 1%. If you put the confidence level at 99%, and then you will take a p-value of less than 0.001 as a significant. And the other way of looking at statistical significance is your 95% confidence intervals, which could be calculated for means, proportions, difference of means, difference of proportions, for ratios, odds ratios, relative ratio, anything for area under the curves, we can calculate 95% confidence intervals, anything. What does 95% confidence interval mean? Whatever range, we get a lower bound of 95% confidence interval and an upper bound. This range tells me that true value, there are 95% chances that the true value lies in this range. I'll take some examples. Say, for example, in a population where I find the mean difference of duration of stay in two types of surgeries is 5.5 days, 95% confidence intervals are 4.5 to 7.2. That means even though I observed a mean difference of 5.5 days, the true value, I'm 95% confident that the true value lies between 4.5 and 7.2. Now, these 4.5 and 7.2 are narrow confidence intervals. It means if I do this study 100 times, out of those 100 times, 95 times, I'll get the mean difference between the range of 4.2 to 7.2. But if I get my 95% confidence intervals as 1.2 and 19.5, that means if I keep repeating my study 100 times, 95 times, the difference could either be 1.2 or it could be as large as 19.5. So these are wider 95% confidence intervals. Then I have a third example, which is minus 3.2 to 8.5, which means these confidence intervals which are crossing zero, the one lower bound is less than zero and the upper bound is more than zero. That means in two groups, the difference could be plus on the different directions. So these are statistically non-significant 95% confidence interval. The first two ones are statistically significant. The first one is reasonably narrow 95% confidence interval. The second one is significant but wide confidence interval. And the third one is statistically non-significant 95% confidence interval in mean. Then similarly, we can also calculate 95% confidence intervals for proportions. The difference of mean or proportions should not cross zero. The 95% intervals should not cross zero. And ratios, for example, odds ratios and relative risk should not cross 1, as was shown on the forest plot, that line of equivalence, that is 1. If it crosses or the 95% confidence intervals on the both side of equivalence, line of equivalence, then they are not significant. So I think I'll end here. And if there are any questions, I'll be very happy to answer them. And thanks for patient hearing. Thank you.
Thank you, Dr. Satish sir. You have tried to explain it in such a comprehensive way. I know it is very difficult for obstetricians and clinicians to understand the statistical analysis, but definitely if your statistical analysis is good, only then you can have some, concrete conclusions about your study, about all the labor you have put in the study you have conducted. So I will just summarize that whatever medical statistics we are using as a clinician, it is just a descriptive information you are giving to your study. Then statistics may be, giving you association between various variables you have used in your studies. For example, the association between particular risk and the disease it has led to. Then you can use statistics for comparing the various newer and old rates. So statistical analysis becomes very, very relevant when you are going to reach the conclusion of your study, when you are going to prepare the summary. All these things become very, very relevant. And I know it becomes, sometimes difficult. We may take help of statistician also for the analysis, but we all must know the basics of statistics. Thank you, Dr. Satish sir, for very comprehensive. Your presentation was very comprehensive. And if there are any questions, we can take one or two.
Dr.
They want your table to be shared about the various tests to be used for analyzing.
I think
So you can repeat in one or two.
This was not a very comprehensive table for all the tests which were done in statistics.
Which one you are commonly using in your clinical studies?
Pardon, say it again.
Which one you are using in your studies, sir? That is the thing people.
Software we use.
Yeah, which tests you are using in your?
Yeah, that will depend on the study design, the outcome measures, your variables, and then whether it is a continuous variable we are analyzing or a categorical variable we are
Dr.
analyzing.
Anita, Dr. Sir is a pillar of our protocol committee.
Wow, great.
All the thesis in Gangaram Hospital goes through his guidance.
Right.
He guides all the students in our hospital.
My one question is, how much statistics do we as gynecologists are supposed to know? Because
even if you don't want to know statistics, you should learn or know that what answers you are trying to find out from your data set.
Yes.
So you should understand your data,
that is what we have to
your
understand.
variables. You may not be able to perform statistical analysis because whenever you're going to a statistician, you should be very clear in your mind that what are you trying to find out from your data. So I should go to my statistician and say that, okay, I've collected data in this format, that these are my variables and these are the answers I'm trying to find from my data. That's very important for an obstetrician or for a neonatologist for that matter. Each one of us doesn't need to learn statistics. But yes, we should need to learn our protocol, our data collection methods, methodology, and we understand our variables. We understand our exposure variables, our outcome variables, my groups. So I need not learn regression analysis, but I should know that I'm looking for prediction. I'm in a prediction model. I'm looking at risk factors prediction or utility of a test, or I'm comparing means, or I'm comparing proportions. So if I know that, that is good enough for clinicians. I may not be able to perform those analyses. So otherwise what happens is you just dump data to the statistician. They will do all sorts of statistical analysis on that data and give you some tables, give you some p-values, and then you are at a loss how to interpret that data sheet and how to prepare your results and how to interpret them.
Definitely, Maninder ma'am, and your statistical analysis becomes the background of your visual depiction also. Means at least we can learn how to read tables, how to read graphs, and how to calculate percentile and all these variants. These are basic things I think all obstetrician must try to learn.
Yeah.
I think
Congratulations, because you made everything so clear.
But I would say one thing, that we should be able to make a plan for our analysis, even though we may not be able to do our analysis. That's my request to all of you. That we should be.
The first thing which I do when I make a study, I go to a statistician to tell me first the thing is the sample size, what I'm going to look into, and what is the sample size I'll be needing, which the study should be having.
But does the statistician not ask you that to calculate sample size, I need certain information from you?
No, he wanted the population and the incidence and the prevalence from me.
Absolutely. Absolutely.
So that's my questions and hypotheses on that.
We have to understand that what information we should be taking to the statistician to calculate the sample size. I may not know the formula, but as a researcher, I need to take some information to the statistician to help me calculate the sample size.
Yes, that is what. So what I have done now as editor of JMH is, I've invited a couple of biostatisticians also as a reviewer, because many studies, they have so much of statistical analysis done, which are beyond our knowledge to understand what are their data. So they have agreed anyway. And Dr. Satish, you have done a wonderful job. And I might be needing you in future also, because we are going to continue with these webinars. Mala Srivastava has done an excellent job. And I didn't know the Gangaram had such a juice in their armamentarium of this thing. For me, Gangaram was more of a practitioner's place rather than a researcher's. But I don't know, it has changed into a researcher's place, I think now.
One thing I will like to ask you, when to use percentiles and when to use quartiles. So that is one thing I'll like you to explain.
Quartiles are also percentiles.
Okay.
If I have a population, I arrange them into ascending to in an ascending manner or a descending fashion. Then my first person is first percentile, my 50th person is 50th percentile, my 75th person is a 75th percentile. So my quartile is quarter. So 25th person is first quartile. My median, which is 50th centile, is my second quartile. My 75th percentile is my third quartile. And I know that if I know the median, that means 50% of my population is below the median and 50% of the population is above the median. If I know the first quartile, that means 25% of the population is below the first quartile and 75% of the population is above the first quartile. Similarly, when I know, this is basically to know about what is the variance and distribution of my data, or dispersion of my data. For example, if I know the mean and standard deviation, I know that mean plus minus 1 standard deviation has 66% of the population, and mean plus minus 2 standard deviation has 95% of the population. So I know that if my mean is 5 and my standard deviation is 1, that means 95% of my population is between 3 and 7. That is plus minus 2 standard deviation. Similarly, if I know the median and IQR, then I know that what proportion of population has, say for example, if I'm looking at the age of a population and the mean age is 50 years and the IQR is 25 and 65. So I know 25% of the people are below 25 years of age, 50% of the people are below 50 years of age, and 75% of the people are below 65% of age. So that is how we use this information to know your population or your variables.
Thank you, sir.
That was an excellent talk, sir. And I'll just add into the thing is another important aspect where a clinician feels important to know the basics is interpretation of this data. When you want to take anything from the paper to the clinic, we cannot adopt anything to our practice. So whenever we read a paper, I think we should know the data interpretation more rather than conducting statistics. So whenever we look into a table, I think we should know where the data falls. And I think major papers have faults at multiple levels, but probably we should not blindly accept data. So that's another point I wanted to add. And it was an excellent presentation, sir.
That's an excellent point, Dr. Rahul, that very often you look at tables, and if you understand the data, you are able to pick up those mistakes. Like, for example, APGAR score. People often report APGAR scores and mean and standard deviations. But you cannot have a APGAR score of 7.5 or 8.2 or 8. So it would always be nice that you present your ordinal data as median and IQRs. So if you understand your data well, you are able to interpret other people's results also equally well. That's very well said, Dr. Rahul.
Please introduce next speaker, Dr. Rahul.
Yeah. Thanks, Mala, and I'll leave.
Thanks, sir. That was the excellent scientific deliberation, sir, as always.
Okay, thank you. Thank you all of you.
Dr. Satish, wonderful presentation.
Very nice.
Thank you all of you and good night.
So for our next speaker is Professor D.S. Sampath Kumari. Madam is Chief and HOD of Muthukumaran Medical College and Research Institute, Chennai. Madam has been Vice President-elect of 2022 for FOGSI, and she has had multiple prominent positions. And,
thank you, sir. Dr. Rahul, thank you.
I think the stage is all yours, madam.
Ma'am is a great academician, I must add. She's a great academician.
I'll share my slide. Thank you so much. First of all, I thank AOGD Zonal Committee of IMS and Sri Gangaram Hospital and SMLM for the wonderful webinar. But only one request to Dr. Mala and Dr. Maninder and Madam. Madam, you should keep this program in Sunday, Madam. All my PGs will see. This is not the ideal type. because you have a good speakers. I am going to steal all the speakers and do the same program in TNFOT. In Tamil Nadu Federation with Dr. Mala's permission.
Invite us again. Invite us also.
Yes, madam. It's a wonderful talk. All that to the statistics and everything and all. How many times if we listen also, we will be in the confusion.
Yes.
So it should be very, very useful to the students. Next, I'll come. My topic is very, very simple. What is ethics? I'll go with this. See, now you have been hearing all the topics about how to select the research methodology and the guides role and the statistics and everything. Then with the sum of research, what is the ethics? Whenever you take a topic for a research, there is two things. What is the objective and what is the risk and burden? The ethics should be between this. The objective should outweigh the risk and burdens. This is the ethics we follow. So whenever you do the research, what are all the risks and what are all the results it is coming? It should be continuously monitored. But when a stage comes, when the risk and the burden outweighs the objective, means you should be in a position to modify your protocol, or in sometimes you can stop the study also. So this is the ethics we have to follow. So each for the ethics, always if you want to do a research work, we should have a protocols and the principles of declarations. In the protocols, we should mention who is funding your project and who are all the sponsors, which institutes it are affiliated, whether a single institute or many institutes, and what is the conflicts of interest. Everything should be mentioned in the protocol. For it should be known but to the researchers and to the participants and all. And finally, in a clinical trial, the protocol must also describe the post-trial provisions after the study. What is the result and what it could be, whether it can go to the next stage. These are all the ethics which has to be followed. So whenever you take up research, even now the dissertations or whatever it is, nowadays it is very, very essential to be presented in the ethical committee. Even presenting in the journal also, you should present in the ethical committee. Not only presenting in the ethical committee, throughout the project, you have to tell what is the progress and what is the positive things, what is the negative things. Everyone has to be reported to the ethical committee. And the final report after the project is over, this is my positive report and this is my negative report. Whatever the report, it has to be told to the ethical committee. So this is one thing. So the previous speaker itself mentioned this, whatever a study, whether it is a small study or a big study, it is better to have it in the registration. If it is a registered, means it will be good. These are all the basic ethics we should follow whenever you do your research in a scientific process. This, whatever I have told, this comes under the class 23. That is how the ethics has to be followed in a scientific research. See, when you do a scientific research, you should be very honest. If you are taking for a 50 patients only, you should mention only the 50. Nowadays, what happens sometimes is this 50, they make it as 100 and give the reports. It should not be there. So the honest and integrity should be followed. Whatever you tell, that has to be promised, followed till the end of the project. What the studies you should, and you should not counteract with what the project it has been sent. So the honest and integrity is very, very important. Next, the objectivity, always. So it should not be with the subjectivity and it should be with the objectivity, whatever the interpretations and peer review. For example, if you tell that a cervical dilatation means it be subjective, some may have a 2 centimeter, other may have a 3 centimeter. But for the research, you should have a fixed, that is the objectivity should be fixed and it should be followed throughout the protocols. And that should not be the carelessness, negligence and simple error. Sometimes what will now know, if you see the Excel sheets also, 5, it will be mentioned as 50. Sometimes some small careless mistakes. That should not be followed. So this is one of the ethics which has to be, you should have a good records of research activities with good data collections. And the research, whatever you do, it should be open. As I told you, we are presenting in the ethical committee. If you have 1 author or 2 authors or 3 authors, and it should be in the participants, everyone should know what is happening. And it should be, and sometimes whatever it is, that is the transparency. How many data? 50 patients you have collected, 75 patients collected. So 50 patients, the results is so much. After 75, how the results are, whether it is going up or whether it is coming down. So that should be open discussions and the transparency should be done. So whatever you do a research, It is better to have the departmental itself a meeting with every month and what is the progress, like we are doing for the dissertations. And the accountability. See, for this, for example, in the COVID era, we have taken the COVID vaccine for health workers and the COVID vaccines for normal people and the COVID vaccines for patients. In this, what happens? The health workers are very, very close to the COVID patients. So what is the result with the health workers and what was the result? You should have an account what was happened and it should be given shown to the others. Accountability and confidentiality. Suppose if you are dealing with a HIV patient, antenatal patient with HIV, and sometimes the MTP patients, who nowadays we have the respectful abortion care, whether you're married or unmarried. So the confidentiality, whatever is needed, only it has to be done. But some patients, it not to be mentioned in the open way. You can mention it as A, B, C. Some numbers can be kept up. So for the ethics, the confidentiality is very, very important. Then comes the intellectual property. Most of the time we collect the details from the media or like that. In that and all, we have to see some, whatever the data, if it is not permitted from the ethical committee and some unpublished data, if you are voting for the reference, it is not acceptable. So it has to be with the intellectual property and it should be with the laws, local laws. Some state will have some laws and other state will have the other institutional and government policies, laws and the government policies. It should follow whatever the study you take. It should be for it should be acceptable by that state and that the institutions and the government policies. And if you have any animal studies care, nowadays they don't have, if at all it is needed, they should not do some unnecessary things to the animals. And the human subjects protections. So if you are doing a newer drug to the antenatal patients, and if you want to study, and if it is accepted also, because of this drug, what side effects can happen to the mother and what side effects can happen to the mother, that you should analyze it. Then only you have to proceed with the study. So the human subjects, the protection is very important. And once, always it is better, whatever you have done after the studies, it has to be published. Responsible publications with a good professional knowledge, it has to be published such that some other peoples will read that and it will become a responsible mentorship and they can do a other study which is better than this present study. So responsible publications and mentorship, these are all the ethics which is needed. And you should whatever, if you have taken some studies, once the study is over, acknowledge them and respect your colleagues and the social responsibility that is prevented. If the patient who is under the study, if she is feeling that I don't want to be in the study, means we should allow her to go out of the study. This social responsibility is also important. Then this non-discrimination. When two people are doing the study, if you are giving a positive to one study and if you are going to be partial to the other study, it is not acceptable. So it is not a non-discrimination, it should not be present. And whatever the research you do, it should be the professional. So for now the competence is more. So the next study should be better than this study. So the professional competence is also important. So these are all the things which you have to be with the ethics. What are all the principles with the ethics? With your study, what is the benefit to the society? And what is the welfare of this research? Whether you got the informed consent from the participants. This informed consent should be in the same language. It should not be in the different language. The patient should understand the language, what it has said. And what, as I told, the non-discrimination, non-exploitation, conflict of interest. These are all very, very important with the ethics. Then, as I told, confidentiality and privacy. If the patient has some important details, means it should, if he wants, has to be given. Mainly, if you are going to do with some research with adolescents, the privacy is very, very important when you are examining the patients also, it is very important. And the professional competence and the discipline. So with this discipline only, it should be a mentoring and it will be a teaching for the other studies. So what are all the principles you have? It is categorized under the 3 topics. Ethical, scientific inquiry, and ethical with the researcher's conduct and behavior, and ethical treatment of research participants. Duty to the society will come under the scientific inquiry. So what the researchers would conduct himself with the manners, it will be in this category will include the conflict of interest, integrity, non-discrimination, professional competence, and professional discipline. And with the participants, that is the ethical treatment of research participants, the other categories, informed consent, beneficence, non-discrimination, non-exploitations, privacy and confidentiality. These are all the ethical principles which has to be followed whenever you go for a research in the field. Ethical may or may not agree with the local laws. So again, this ethical principle may vary across. If you are going with an animal study or if you are going with a human study, there may be the difference. And again, with across the countries, depending on the place, the local laws and the oversight enforcement, the ethical principles, there may be a slight variation. Here comes the Helsinki Declaration. What is this declaration? The researchers, authors, sponsors, editors, publishers, all have ethical obligations with regard to the publications. This Helsinki Declaration was formed with so much riches. This is the World Medical Association. With this, they have formed from 1964 to 2011. Finally, only this Helsinki Declaration was formed. What does it mean? It tells that the ethical principle for medical research involving human subjects, including research and identifying human material data, it is very, very important. So the Declaration of Geneva, what they tell, the health of my patient will be my first consideration. So the patient's health is very, very important. And the physician shall act patient's best interest when providing. So whatever the research you do, the patient's health and the patient's interest is very important. So first we have been seeing about the ethical principles, and now we have saw all the research methods, whichever method, what are all the consideration with this, whatever topic you take, whether it is fit with the chosen method and whether it is suitable with the real life situation and whether it is appropriate and the adequacy. For say nowadays you have a sample of 50 and if you give a result, it may not be successful. Adequacy, at least to tell a positive point, you should have a sample size of about 200 to 250. Then only the results will be very good. And the transparency, authenticity, these are all. And the findings, the data, whether all the data is very coherent, where it suits with your topic, unnecessary topics, whether the data which you have collected is not suiting your topic. These are all also the consideration which has to be concerned with the research. And the permeability, the research intention, the researcher's intention, preconception, values, or whether revealed in the report. In the final report, everything has been reported. These are all the consideration which you should take with the ethics. Then comes the placebo. Sometimes we give some drugs to one group of patients and another to the placebo. There is again a debate when there is a treatment for a disease, why you want to go with the placebo. So there is the ethics of using placebo is again debatable. So whenever there is a final, what to tell, particular treatment is there, and if you are going to compare it with a placebo, that will not be a good ethics. See, there is one study, this is Tuskegee study of untreated syphilis. This is long back, but to mention the unethical research, you can have this example. This is the prospective cohort study funded by the US Public Health Services. That is done for 40 years. In that, what they have done, they have taken 600 poor illiterate black men. Of this, 399 were with syphilis and 201 were without syphilis. But no treatment was given. It was followed for 40 years. Finally, what happened? They were not informed about the consent and they were not informed about the side effect. So with this, what will be the, in these cases, as I told earlier, the objective and the risk and burden. The risk will overweigh the objective. This is the unethics which was done. Example for the unethical study. What are all the principles violated in this study is beneficence, respect of autonomy, truth telling, and justice. They didn't have the justice. With the syphilis patients also, they didn't give the treatment. Finally, they ended with the complications. So the ethics, whatever you do, already you had the discussion about the plagiarism. So it should be free from this. You should not copy from the others. Nowadays, a sentence copying, paragraph copying, though we have the methods that has to be, and the publications that will be modified and the duplicate publication is there. That should not be there. And the ghost authorship that we had already. For one of the author may not have contributed anything to that article, but still their name will be there. This is the ghost authorship. We can mention it as also as steal authorship. So any form of bias, whatever it is there, it should be fabrication and falsification. That is data which is adding and which is you could have done 50 cases, but mentioned as 100 cases. This should not be done. So unethical research means it should be beyond ethical concern and the scientific misconduct, authorship, conflict of interest, and mentorship. Other considerations with the if you are going to publish a research, the scientific, what are all the other considerations means over-interpreted data. See, that only when they will have collected 200, but they will mention as the 500 cases. and author, a particular author, they will be telling, in my experience, I saw this patient and this is my patient. That should not also be there. And over self-referencing and the salami science. What is salami science? You are collecting a data, but the data is split into 3 or 4, and there might be 4 or 3 or 4 publications will be done. This is the salami science. That is the data that has clearly been split into 2 or more parts, like a salami slicing way to publish more than 1 manuscript. These are all the other conditions which should not be followed. That if it is followed, it will not come under the ethics. So finally, the fact is, it depends on the individuals, and it should be familiar with the reporters. And if you are doing one study, means should be given only with the 1 publications. Don't go with many publications. And as approval with the ethical committee, and the licensing should be done. This is another one thing which I want to mention. That is Nuremberg Code 1947. In this, what happens? The Nazi experiments are, they are allowing the participant to be placed in the freezing water, and they watched till the time of the death. How long, how many years, and how many weeks, like that. And the participants were allowed to give the seawater, and the adverse effects were measured. These are all the examples. This is mentioned only to understand what is the examples for unethics. Similarly, with the American military tribunal, they are accused of war crimes with the conduct of research on the prisoners. These are all the unethical points. So what is this? The Nuremberg Code was published in 1945. And this is the fundamental document if you want to know about the ethical research, guiding ethical behavior and research on human subjects. Similarly, with the US, it has the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. So I think these are all the ethics we have done. Finally, the International Committee of Medical Journal Editors, they have mentioned the patient's right to privacy and identify the information. They may have some information and they don't want the name to be published, and the non-essential things need not to be mentioned in the topic, whatever the project you have done, and sometimes masking the eye region in the photographs. These are all published by the ICMGA, that is the International Committee of Medical Journal Editors. So as a recap, if you are going for a scientific research, what are all the ethics? First is integrity, respect, rules, regulations, justice, dignity, confidentiality, competence, moral principle, ethical practice, values, privacy, honesty, beneficence, autonomy, and non-malfeasance. These are all the ethics you have to follow. Once again, I thank Dr. Mala and Dr. Maninder Madam for giving me an opportunity. The references which I had is the guidelines, ethics guidelines, and the CSR guidelines, NIH guidelines, PhD research guidelines. Thank you.
It was an excellent scientific deliberation, Dr. Sampath Madam. And you have really clearly outlined the ethics of a scientific research. It's my pleasure to invite our next speaker, Dr.
Mala, can I ask one question?
Yes, ma'am.
Just one. Dr. Sampath, it was an exclusive, wonderful, and I think the ethics developed from the war crimes itself. That was the origin of the war crime. What I wanted to know was, you said the slicing of the data is not allowed. That means multiple studies being. But when we are doing reanalysis of those studies like WHI, so that is allowed. That is a reanalysis that's different from this thing. Because
normally what they did, they collect the data, but the data they divide into 4 particles, and the 4 articles will be published in 4 journals. That is the one. If you want to do means, if you are focusing for this research, you focus on this, and then you go for the other research means you do it again in the second. That is the salami guidance as far as this WHA. But most of the people, see, madam, even with the PGs, with the dissertation, they publish in 5 journals when they became an assistant. So that is not allowed. That is the only thing we are all over, whatever we are telling, but still this unethics are going on. That has to be put an end.
Ma'am, it is important to take informed consent in the subject's language. That is also very, very relevant, as was highlighted in previous presentations also, ma'am. And if the patient, the subject should have, we should honor their decision. If they want to, stop being a subject, during the study, they can withdraw from the study. Yes. That has to be explained in writing to the patient. And it should be clearly mentioned that there will be no harm caused to them during the study.
Actually,
So Sampath, very nice talk, Dr. Sampath. Asha Rao here.
Yes, madam.
Very clear presentation. Enjoyed it.
Ashish sir wants to make a comment.
Actually,
Ashish
about
sir.
that patient information, if you don't have that written in your approval for internal ethics committee, they will
not
you
pass.
approval
Yes.
if you don't have a proper patient information sheet and the consent. And
Yes.
if they want to be part of the proper follow-up studies, again, you have to take consent from them that yes, if the proper follow-up is there, they would like to participate.
They can drop out of study. Yeah, they can drop out of study. That is an option we
Everything
can.
has to be there in writing.
Writing.
Otherwise, we don't get the ethics clearance approval. We
Madam,
don't
even
get
that, what happens to the retrospective studies? Is it necessary, the consents?
Retrospective, how can you get the consent? That's all.
Yeah, that's what I'm asking. So you can't definitely get it.
Ashish sir wants to make a comment. Ashish
Asha,
sir.
if you have to retrospectively studies, where are you doing it? You are going to do from some data, registry somewhere. So you will have to take consent from them. They have to give you the permission because that
From
is privacy under privacy clause. They cannot share with everybody.
That is not consent.
So if I'm doing from my hospital, our center,
that is permission. Okay.
That's how I'm asking.
No, what I wanted to say, Sampath, I must.
Yes, sir.
Because I have seen my seniors taking pride that they have taken out 3 publications from one single publication.
Yes.
We used to look with some respect and awe to them. Today, we realize that that was unethical.
Yes, sir.
Thank you, Sampath Kumari, for raising this issue. And I believe that this should be circulated among all the,
Yes, sir. Thank you, sir.
Teachers.
And teachers, yes.
But they are doing the maximum research. Private practitioners are hardly doing any research.
I see maximum banta hai, madam.
It's my pleasure and privilege to introduce the next speaker, Dr. Ashish Khaji, Dr. Ashish Kumar Mukhopadhyay. Sir has been Principal and Professor, Unit Chief of CSS College of Obstetrics and Gynecology, Child Health, Kolkata. Sir has been Head of Department of Medical College, very prestigious Medical College of Kolkata. He has been the Vice President, FOGSI, Governing Council Member, ICOG, past President, Bengal OB-GYN Society, ex-Chairperson, Medical Education Committee. Sir, floor is all yours for your scientific deliberation. What does the reviewer and editor's choice? Over to you, sir.
Thank you, Mala. Thank you very much for this kind bit of introduction. And I don't know how much scientific it will be at 9:40 p.m.
We are all awake.
When I can see that Maninder has already had her dinner and have also gone for dinner. But I think that I wish to thank them profusely. What a webinar it has been. So all kudos to Dr. Mala Srivastava, Dr. Maninder Ahuja, and all the participants, all the chairpersons, all the learned, faculty. They have done wonderful job. This is really some kind of feast, academic feast, I must say. And Maninder deserves special congratulations for that, and also Mala. Secondly, you must be wondering that most of the time when the webinar was on and the honorable speakers are deliberating, then my video was not visible and I was not talking also. You must be wondering, what am I doing? I think you guessed it right. I was reviewing. So I was reviewing and editing, and which is done actually from the background, and nobody comes to know who is the reviewer or who is the editor of a publication. And that's a silent job that they do, but they are very, very, very important in the publication. In next 10-15 minutes, what I will do, I will try to see what does the editor and what does the reviewer do with a scientific publication. And Mala, please, I've already deleted 10 slides, so don't tell me to shorten the lecture further. So what is a review basically? A review is a survey. It's a survey over a whole subject or a part of it, especially or an article, making a critical reconsideration and summary of something which is written. So that's review. And review it to the naked eye, it sounds very simple, but it isn't that simple because it has got certain processes and it's quite complicated at times. Now, who is a reviewer? A reviewer is a person who writes critical appraisal. Sorry. is a person who writes critical appraisal of books, plays, films, etc. for a publications. A person who formally assesses something with a view to changing it is when necessary. That means he has the capability of changing also. Who can play multiple roles of a critic, commentator, reader, and inspector, judge, value, referee, author, etc. One who undergoes a review is a reviewee. That means our candidates, the students, are reviewee. The ultimate decision always rests with the editor, but reviewers play a significant role in determining the outcome. Let us see how. Reviewer's job is a step-by-step job and escalating gradually upwards. Before taking up a review, the reviewer usually looks for the abstract. So whenever you send some publication for review, you must see that the abstract is there. And the abstract has to be there in the publishable format. That means all publications abstract must be visible to the reviewer. And that is the beginning of the review. There are two ways of review. One is formal way and one is informal way. Well, mostly we do the informal way of review, but more scientific is the formal way. In the formal way, what do we have? We have the questionnaire is set by the journal, in which they have set up some questions on which it becomes objectively structured. And you answer those questions and the review becomes easier and objective. And I think that is more acceptable than an informal way. Now, the of review process is just a step-up process, as I said, and it starts with a first read-through, which roughly takes 15 minutes time, which is a kind of bird's eye view, and it will help him to preliminarily make an idea whether to accept it or reject it. I mean, you get an idea whether the article has to be accepted or rejected, but you hold it there. You do not do it describe the result right now. A more detailed and in-depth second read through a study follows in an analytical frame of mind that is more important. So let us see what are the steps of review. The first, as I said, you go through the abstract, take the preliminary decision, your impression is made. But now you ask some questions to yourselves. Number one, main study question behind the research and how relevant it is. In this webinar, a lot of speakers have dealt with this study question, and therefore I won't repeat on that. It's an extremely important part of a study. And the basic question, the study question, has to be defined very, very clearly. And nothing is more important than this to a reviewer. Originality of the topic, that this has also been discussed, whether the same topic has been published very recently or not. Quality of the writing, is it lucid, easily understandable? You have to remember that this has to reach the population, general population. Do the conclusions address the main question? So you jump to the conclusions at the first brief reading. So you quickly see the abstract, answer these questions, go to the conclusions, see whether the conclusion addresses the main question. Do the conclusions tally? Sorry. Do the conclusions tally with the evidences and arguments in the text? Is it in complete contradiction to the existing established facts or protocols? And do the tables and graphs correspond with the paper, or they are out of context and irrelevant? Now, these are the basics of the first job, step by step. Whenever you catch hold of an article or a publication, you just do this exercise, which takes roughly 15 minutes time. Now, if you find a major flaw in the methodology, like the conclusion doesn't match, or they're not supported by the facts and figures in the study, use of a discredited method, etc., etc. Or if the methodology is proper, then also look for data tables, figures, charts, etc., to look for insufficient or unclear or contradictory data. So that's what happens when you find major flaws. After this, you summarize the first reading. The first reading, that is 15 minutes time, you have to summarize. And I, as an old man, I always believe in pen and paper. And what do I write on a piece of paper? I do not keep it in the laptop or in my mobile. I just put it on a piece of paper, or rather my copy. You write in two paragraphs. The first paragraph, you write the research questions addressed or not. You repeatedly ask this question yourself throughout the study. And the second paragraph provide a conceptual overview, like, is it interesting and important? With the proper methods used or not? Conclusion supported by data. So these are the three or four basic questions that you ask yourself. Write it in right now in two paragraphs. In these 2 paragraphs, decide if the manuscript is flawed or not, and whether it should be rejected because of a major flaw. If you find a major flaw, these are major flaws, then you decide outright that it has to be. It is not the thing that is which is going to hit the bullseye. So therefore, it is in the negative marking. But do you reject it after the first reading? That's the question. A reviewer never rejects it after the first read. Why? Because there may be some positive aspects which needs to be communicated to the reviewee, and this will help him in resubmitting. Remember, you have to resubmit this thing publication once again, and maybe you may or may not be able to do this reviewing once again of this data, of this publication. And there is a way in which you can communicate that, yes, I am interested in reviewing this after this correction. That is also possible. You make it clear to the journal. What is the benchmark criteria for acceptance of any publication? The benchmark is whether the manuscript makes a useful contribution to the knowledge base or understanding of the subject matter. Somehow, somewhere, if the reviewer gets this idea that this is going to be you make a useful impact or useful contribution to the medical science, then I think it hits the bullseye, and therefore the reviewer then pardons many of the offenses. Remember, completeness or comprehensive study is not an issue, because basically we must realize that all the studies are incomplete in nature. Whatever study you do today, there is somebody who is going in once again tomorrow to do it, and therefore look at it from another angle. So completeness and comprehensiveness is not the issue, but whether the data, not the data, whether the objective of the study has been fulfilled and it has made a useful contribution to the medical science. That is the only thing that the reviewer always sees. And the editors always say that you please offer clear suggestions for how the authors can address the concerns raised if you have the concerns. In other words, if you are going to raise a problem, provide a solution. That's what the editors always say to the reviewer. Remember, reviewers are always in communication with the reviewers. Now the second read begins. So after you have completed the first read, which takes roughly 15-20 minutes time, the second read begins, which actually for me it takes 2 to 3 hours time. I don't know about all of you, but it takes 2 hours time minimum for me, the comprehensive read. So what are the questions now? The questions changes. The title and the keywords, do they reflect the content? Now this is the first question. Is the abstract an accessible summary of the paper? Is the abstract available? Is it available to all? That is a mandatory criteria for a publication to be okay. Length of the paper, is it appropriate? Whether it is too long or too short? Are the key messages short, accurate, and clear? So these are the 4 key questions which is hitting you at the beginning of the second read. Next, check the language. Make sure that the text meaning is clear. Not everyone is an expert in writing language, and therefore do not bother about the language too much. But if you have some problems, you suggest the improvements to fix the problem. That's the reviewer's job. And you may have some communication with the editor also. How? The editor chips in here. And the editor says, if a manuscript has many English language and editing issues, please do not try and fix it. That means you cannot go on correcting the English language page after page, line after line, etc. If it is too bad, note that in your review, and it should be up to the authors to have the manuscript edited. That means it is the job or responsibility of the author to correct the language and get back to you. So that's very important. Now, who is an editor? Editors, they always plan, revise, and coordinate material for publication in newspapers, magazines, books, or websites. They also correct grammatical errors, spellings, and punctuation. They may rewrite the text so an audience may easily understand. Suppose the language which is not easily understandable to the lay people, then it's the editor's job to make it changed. They must verify facts with standard reference sources and evaluate submissions from writers so they can determine what to publish. And they may also suggest headlines and titles. So they can do many things, but the initial input must go from a reviewer to an editor. What about grammar and punctuation? The primary role of the reviewers and editors is judging the research content, the scientific content. So it is unwise to spend time correcting grammar or spelling. Editors will make sure that the text is at a high standard before publication. So it is the editor's job. However, if you spot grammatical errors that affect clarity of meaning, then it's important to highlight these. Now remember, if the grammatical mistakes are there, notwithstanding the meaning is clear to the reader, then it doesn't really matter. But it's rare for a manuscript to pass review with no corrections. At least it hasn't happened with me till date. Now the second read continues. Now come step by step. So after the initial part is over, now you go heading wise. Introduction. First is the introduction. A well-written introduction, aims and objectives introduction. A well-written introduction should set out the research question, which is very, very important. And the reviewer must ask himself whether it has set out the research question. Gives a very brief summary of research related to the topic. Highlights the gaps in current understanding or knowledge, because if there is no gap, there is no need of a publication. Establishes the need to investigate the topic and novelty and topicality of the manuscript. So these 5 questions must be clear in the introduction, and that the reviewer has to see. I know it's the guide, it's a role of the guide to put in all these things in order so that the reviewer gets to know all these 5 points before he reviews, or while he reviews. Now the editor's views on originality and topicality. Originality and topicality can only be established by recent authentic research. For example, it is impossible to argue that there is a conflict of current understanding by referencing articles that are 10 years old. So now you have to have a quick look at the references as well. I'll come back to the references later on also. And the editors say, is the report providing new information? Is it novel or just confirmatory of well-known outcome? This is known to a reviewer also, but he just keeps reminding that whether it is adding some new information to the medical science or not. And to set out all these things in practice, we have an organization called COPE, C-O-P-E, Committee on Publication Ethics. COPE is a non-profit organization dedicated to promoting integrity in research and its publication. This is actually Willy International's branch. COPE serves more than 12,000 members around the world with practical guidelines, resources, e-learning, seminar, and much more, and they're spreading knowledge and awareness. COPE have defined a set of recommended core practices that are applicable to all involved in publishing scholarly literature, editors and journal teams, publishers and institutions. We have to also remember that the reviewers and peer reviewers, they are 2 different things. Peer reviewers are actually quality reviewers, which consist of a separate group, which is kept beyond the scope of this discussion. Now come to the second point, that is materials and methods. Academic research should be replicable. By that, what we mean? Replicable means could be repeated by any other researcher. Where research is not replicable, the paper should be recommended for rejection. That is very important. It has to be replicable. Second is repeatable. What is the difference between replicable and repeatable? Repeatable means give enough detail so that the researchers are able to carry out the same research, if not asked to revise. So if it is not repeatable, the punishment is not rejection, but it is revise. But if it is not replicable, then the outright rejection comes. Third is robust. Robust means enough data, quality of data and quantity of data to make sure that the data is reliable, and insufficient data requires revision, not rejection. Fourth is follow best practice. What are the best practices? Standard guidelines for best practices. Statement for reporting randomized trials. The health and safety of all participants in the study was not compromised. Ethical standards were maintained, something so beautifully explained by Sampath Kumari. If the research fails to reach relevant best practice standards, it is usual to recommend rejection once again. So these are the 4 things: replicable, repeatable, robust, and best practice. 4 principles have to be followed. If the research fails to reject relevant best practice standards, once again, you have to do the rejection, and you don't need to read further. Now the results and discussion. The results common question is what happened, what was discovered or confirmed in the study. Data analysis in simple terms, because there are a lot of statistical jargons will be there, which the common man may not understand, but it has to be simplified, and it is the job of the author, which has to be assured by the reviewer. And this has to be conveyed to the committee. Critical analysis of the data collected has to be done in simple language also. And inconsistencies, if any, should be addressed, and future research will be suggested. About the study conclusions, the conclusions must be very small, only a few paragraphs, not pages after pages. May be presented as part of the results and discussion. Nobody minds that. If you put the conclusion, study conclusion with the results and discussion, it doesn't really matter. But it should reflect upon the aim, whether they were achieved or not. You have to check that. If the conclusions are not evidence-based, it is appropriate to ask them. Come to the images, graphs, and data tables. Results tallied with the tables. Check if the images are edited or manipulated. If so, highlight this in a confidential comment to the editor. Never communicate it to the author, but a confidential comment to the editor. Coming to the list of references, you will need to check referencing for accuracy, adequacy, and balance. So there are three things you have to see in the reviewer sees in references. One is accuracy, by which it is meant it's the editor's role to exhaustively check the reference section for accuracy and format eventually when it goes to the editor. Adequacy means are important parts of the argument really important, or similar or dissimilar studies have been taken together, or the references should be relevant, recent, and readily retrievable. So these are the three qualities of the reference. They're relevant, they're recent, and readily retrievable. By recent, we mean last 5 years or last 10 years, not more than that. What is the meaning of a balance of references? It is helpful for the reader-friendly references. Fair to competing authors. Other authors who are going to write this, it should be fair to them. A reviewer, of course, an editor is able to evaluate whether the article meets the criteria for balanced reference without looking up every reference. So that is the criteria of a good references, and this list of references is very, very good. Plagiarism has been discussed many times in the past in this webinar. If the reviewer suspects plagiarism, but if he cannot locate exactly what is being plagiarized, notify the editor in a confidential note and ask for guidance. Most editors have access to software that today that can check for plagiarism. And editors and reviewers are not moral police, but when plagiarism is discovered during peer review, it can be properly addressed ahead of publication. You know what happens when it is discovered only after publication. Not a problem for everyone. Coming to the criticisms and confidential comments to the editors, as I said, this is very, very important that you need to have criticisms and confidential comments without disclosing it to the author. And most journals give reviewers the option to provide some confidential comments to editors. This area is best reserved for communicating malpractice, like for instance, suspected plagiarism, fraud, unattributed work, unethical procedures, duplicate publication, bias, or other conflicts of interest. These have been also discussed in this webinar. The disadvantage is that only the authors cannot see this feedback from the reviewer and are unable to give their side of the story unless the editor asks them to do. That is why the best way for the reviewer is to convey it to the editor because he has access to the author. Now come to the recommendation. What does the reviewer recommend at the end of it? Recommending revision or recommending rejection. If it is accepted, you must write why it is rejected, and the areas that can be improved must be written there. So if you are recommending acceptance, give details of recommending rejection. About the printing mistake. Recommending revision, specify major or minor revision. And if you are recommending revision, editors will say if a reviewer suggests revision, but his or her comments are not detailed or helpful, it does not help the editor. So you have to be very clear cut in making the opinion to the editor. Recommending rejection, give constructive feedback. Just do not write that I'm rejected, something like that. Keep the focus on the research and not the author. When the comments seem really positive, but the recommended rejection, it puts the editor in a tough position. Naturally, don't do that. Don't have a conflicting statement in your statement. Now, in conclusion, I would like to just highlight a few facts. One is that reviewers and editors can act like umpires with a rule book in their hands. They are not against publication, they are pro-publication, but they are just guiding you through so that the publication becomes more scientific. They try to judge a manuscript with an open and unbiased mind, but with scientific intent. Reviewing is a step-by-step process, very disciplined, but committed to execution. Unfortunately, reviewers are not paid well. In fact, they are not paid at all. Reviewers and editors are like covalent bonds, tying the scientific threads together for the betterment of science. Rejection and revision are part of life also. We have experienced in our life. Why blame the reviewers and the editors? Do not get rejected if your paper gets rejected. Instead, follow the instructions. take it positively, and finally rectify and send it. Success will follow soon. And thank you very much for your patience.
Thanks, sir. That was a really very nice scientific deliberation. May we have expert comment from Dr. Asha?
I think so many of us have enjoyed this program, especially your talk. And congratulations to Dr. Mala and Maninder for having organized such a beautiful, fantastic program.
Thank you to all the, I think, speakers and chairpersons and who are sitting here so late and who has given so wonderfully crisp talks that even the people who don't understand, I think, research at all will be now with some positive attitude that at all levels they can do some sort of research. So that is, I think, Ashish, the thought process which we have to carry forward is that all of us can do it and together we can do it. Your last slide, that together we can do it and together we should create more data for the India so that we can bring it on the world map. As far the quality of the evidence is also concerned, so that we are cited more often, as Shobhana said in her introductory address, that we are doing studies, but we are not being cited. We are not cited because I think our quality of evidence is still lacking, and that is where we have to go up. And with the help of all these speakers who are there and researchers who are there, of course, we can do a better job by repeating again and again. If the clinical topics needs revision, so does this topic also needs revision. And thank you to Dr. Mala Srivastava for arranging this everything. She is the, I just gave the idea that I want to do it. Otherwise, she is the one who arranged for everything, all the speakers and everything. And thanks to Jagsonpal, who have been with me, whether it is their product or not, it doesn't matter. Whatever webinar I have to do, they will be there to help me, because I am doing Pearls of Wisdom series also. Just one speaker, one expert, and that's all. 1 hour. But here we needed more people, more thought processes. That is why we involved so many people, because actually we have to do it many times more. I realize it is needed. So thank you to all.
I must thank Dr. Nidhi Narang also, the master of ceremony, young person who has been throughout the podcast.
Where is she?
Thank you, ma'am.
Sort of behind the scenes.
My pleasure, ma'am.
At her again. Yes, Riddhi is here. Riddhi, I have to thank you, because without master of ceremonies, we cannot do anything.
Thank you, ma'am. It's my pleasure, ma'am.
Dr. Mala and Dr. Maninder, it was an excellent evening. And I would just add one comment. We have listened to so much, but we have to walk the talk to learn it. And there's a lot of role of mentorship in this. People, senior people who are doing research, who are publishing, they have to mentor the youngsters into this. It cannot be learned overnight. So this is what I would like to add. Thank you so much.
Dr. Deepti, I request all of you please to join with my project of relationship of menopause to metabolic syndrome. It is very much required in this scenario where we are having absolute sort of epidemic of metabolic syndrome. Every lady who is overweight and coming between the age of 35 and 60 years, she is having one of the 3-4 lipid profile and blood sugar deranged or blood pressure. One of these is deranged. So we have to work on a war footing, I think, on this topic, so that then we can create an awareness of some sort. Prevention should be our main focus. That is what I think, because we are working a lot on the therapeutic aspects, of course, but prevention is still not our focus.
So, Madam, those guidelines have been brought out, in which you were also part by Dr. Piyush Ranjan from AIMS.
I was part of that.
Yes, yes.
I was part of that. I'm one of the authors in the East.
Yes, yes, me too. Yeah. So that is why such guidelines are there. They need to be disseminated more. And this is definitely an area which needs to be researched.
I've been talking with him. He was with in my last webinar on metabolic syndrome in midlife, because I've been doing these series also to create an awareness, because that is a multidisciplinary approach. So we have to involve the physicians and endocrinologists and everybody in that. So thank you very much. I think now, Ashish, you also need your dinner.
I think so.
Thank you very much.
Good
Thank
night
you.
and
Good night, everyone.
I like to bring to your, I like to highlight over here that LycoRed is a product on which we have had a lot of research in so many different indications, and there are about 55 publications which are there in good reputed journals. Also in various specialities like gynae, physician, cardio, diabetes, many other things. Apart from this, we have also done a few studies on with Yuliprist in UPA for uterine fibroids, which are about to be published now. One is from RML, another one coming up from AIM, something like that. So these are two products which are research worthy, and we have been doing a lot of research. So Jagsonpal has been a part of these research projects also. Next is our AOGD Delhi PG Forum on 20th June on adnexal mask. So please do join us then. The webinar ID is mentioned over here. If you'd be interested, you could join.